Yes, today we are going to talk today about our health and education symposium in the modern Turkey in the new century of the Republic. So, dear rector, dear vice rector, dear professors and distinguished speaker, it is with great pleasure and excitement that we will welcome all of you here today. I'm stop the sharing of here, and as everybody is here, first of all, I would like to invite in the opening speech our Vice Rector, Professor Dr. İbrahim Hakkı Aydin. The professor will be in the opening ceremony of the Istanbul Aydin University Faculty of Medicine. So today we are going to start with the Professor İbrahim Hakkı Aydin. Yes, İbrahim Hoca, your speech is yours now, and the professor will speak in the native language, and then I'm going to translate it to all of our guests that are here today. So thank you again, and let's start. Evet İbrahim Hoca, söz sizin. Teşekkürler.
Evet, herkesi saygı ve sevgiyle selamlıyorum. Kıymetli hocalarım, değerli katılımcılar, Cumhuriyet'in yeni yüzyılında Sağlık ve Eğitim Sempozyumuna hepiniz hoş geldiniz. İstanbul Aydin Üniversitesi Rektörlüğü olarak sağlık ve eğitim alanlarında ortak bir tutkuyu paylaşan özverili profesyonellerin, akademisyenlerin, araştırmacıların ve savunucuların bir araya geldiği bu buluşmanın önünde bulunmaktan onur duyuyorum. Bu sempozyum bir araya gelip anlamlı bir diyalog kurmamız, yenilikçi fikir alışverişinde bulunmamız ve sağlık ile eğitimin kesiştiği noktada yatan çok yönlü zorlukları topluca ele almamız için önemli bir fırsatı yaratıyor. Bu alandaki bilgi ve ilerleme arayışımız yalnızca entelektüel büyüme olan bağlılığımızın bir yansıması değil, aynı zamanda topluluklarımızın refahı ve gelişimine yönelik sorumluluğumuzun bir kanıtıdır. Zira sağlık ve eğitim, müreffeh toplumların üzerine inşa edildiği temel taşlardır. Sağlam bir eğitim sistemi, bireyleri mükemmelleşmek, yenilik yapmak ve toplumlarına anlamlı bir şekilde katkıda bulunmak için ihtiyaç duydukları araçlarla güçlendirir. Aynı şekilde güçlü bir sağlık temeli, bireylerin öğrenme sürecine tam olarak katılmak ve fırsatları değerlendirmek için fiziksel ve zihinsel olarak donanımlı olmalarını sağlar. Sempozyumun gündemi en son tıbbi buluşlardan ve yenilikçi pedagojik yaklaşımlardan hem sağlık hem de eğitim sonuçlarını etkileyen sosyal ekonomik faktörlere kadar çok çeşitli konuları kapsayacak şekilde özenle seçilmiştir. Bu sempozyumun hayata geçmesinde gösterdikleri özverilerden dolayı İstanbul Aydin Üniversitesi Sağlık Hizmetleri Politikaları Uygulama ve Araştırma Merkezi'ne, ortaklarımıza ve düzenleme komitesine en derin şükranlarımı sunuyorum. Hiç şüphesiz ki bu bilgi şöleni bilim dünyasına son derece katkı vereceği umudundayım. Daha sağlıklı, daha eğitimli bir dünya olmamıza ilham verici bir sempozyum olması dileklerimle hepinizi saygı ve sevgiyle selamlıyorum. İyi ki varsınız, kolaylıklar diliyorum. Hoşça kalın.
Çok teşekkürler İbrahim Hoca, verdiğiniz destekten ve bugün bizimle değerli zamanınızı ayırdığınız için. Tekrar teşekkürler hocam.
Size teşekkür ediyoruz. Özür dileyerek sempozyumun sonuna kadar kalamayacağım. Başka diğer yoğun işlerden dolayı ayrılmak zorundayım. Hepinize teşekkür ediyoruz. Saygı ve sevgilerimle. Hoşça kalın.
Hoşça kalın hocam, saygılarımızla. Yes. Today, the Vice Rector, Professor Dr. İbrahim Hakkı Aydin, already talked about his opening speech, and I'm going to translate it as he has to be at the opening ceremony of the Faculty of Medicine. So the professor message is like that. Dear professors, distinguished guests, esteemed colleagues and participants, it is with great pleasure and excitement that I welcome you all to the Health and Education Symposium. As the rector of Istanbul Aydin University, I'm honored to stand before this gathering of dedicated professionals, scholars, researchers, and advocates who share a common passion for advancing the fields of health and education. The symposium represents a unique opportunity for us to come together and engage in meaningful dialogue, exchange innovative ideas, and collectively address the multi-phase challenges that lie at the intersection of health and education. Our pursuit of knowledge and progress in these domains is not only a reflection of our commitment to intellectual growth, but also as a testament to our responsibility towards the well-being and development of our communities. Health and education are the cornerstones upon which prosperous societies are built. A robust education system empowers individuals with tools they need to excel, innovate, and contribute meaningfully to their communities. Likewise, a strong foundation of health ensures that individuals are physically and mentally equipped to fully engage in the learning process and seize opportunities. The symposium's agenda is thoughtfully curated to encompass a diverse range of topics, from cutting-edge medical breakthroughs and innovative pedagogical approaches to the socio-economic factors that influence both health and education outcomes. We have the privilege of hosting experts who have dedicated their lives to unrevealing the complexities of these domains and have been a remarkable contribution to their respective fields. I extend my deepest gratitude to our Health Service Policies Application and Resource Center, partners, and organizing committee for their unwavering support in bringing this symposium to fruition. Their dedication is a testament to their belief in the transformative power of knowledge sharing and collaboration. Let us approach these next 2 days with an open heart and an eager mind ready to absorb, learn, and contribute. Together, we have the chance to shape the trajectory of health and education, to usher in a brighter and more inclusive future. Thank you for being a part of this remarkable gathering. Here's to inspiring symposium filled with meaningful discussion, shared wisdom, and the promise of a healthier and more educated world. Professor Dr. İbrahim Hakkıaydın, Vice Rector of Istanbul Aydin University's message is here. So thank you again, Professor, and have a good opening ceremony in the Faculty of Medicine. So now we can continue with the opening speeches of our esteemed guests that already support this symposium. And I just would like to mention before starting that our symposium was organized in collaboration with the Faculty of Medicine and Faculty of Health Sciences. So we can see that in these 2 days, we are going to focus much more in the challenges, opportunity of health education and global health issues and the public health policies. I believe that this symposium will be filled with meaningful discussion, as the professor mentioned, and promise for the healthier and more educated world. So firstly, we will listen to the opening speeches of other esteemed professors and special guests who have supported this symposium. So let's continue with our opening speeches. Istanbul Aydin University's Application Resource Center coordinator, in fact, our previous coordinator that recently already handed over this duty to another professor, and now the first one will be the Assistant Professor Özgür Tör that is going to have this speech. So, Professor Tör, the speech is yours.
Thank you very much. Dear President, dear Rector, dear Professor, and distinguished guests and participants. First of all, I would like to thank dear Dean Professor Ayşegül and Associate Professor Arthur. Why? Because of this very important organization. And we have gathered here today to explain the great progress made in the field of health since the establishment of Republic and the point is reached in the field in the direction of modern egalitarian and forward values that are founding philosophy of Republic. The development of healthcare in our country is carrying major interest. In the first year of Republic, the healthcare was conducted within limited opportunity. However, the founder of the Republic, Gazi Mustafa Kemal Atatürk, and thanks to its visionary leadership in the field of healthcare, important reforms occurred all across the country. New hospitals and new healthcare centers was built, health professional education work was hastened, and some precautions was taken about public health. During the collapse of Ottoman Empire, medical condition was pretty weak due to inadequate base and resources. Hospitals and health centers were limited because of the care and treatment. Epidemic diseases in this period, such as typhoid and cholera, it spread rapidly between the people because of inadequate hygienic condition and medical service. Also, at the same time, nutrition problem created serious health threat, especially in rural area. The risk of spreading disease such as plague has increased due to malnutrition. When all these factors combine, health issue of the Ottoman Empire in the collapse period become prominent that it was seriously weak period. I would like to talk about someone who is important in the field of health. Ibrahim Refik Saydam is one of the 18 commissioned officers who went to the Samsun with Mustafa Kemal Atatürk. Medical doctor Major Ibrahim Refik Saydam is a Turkish statesman and politician who was one of the 10 people chosen by Atatürk, Mustafa Kemal Atatürk, as a deputy of National Assembly from the staff who went to the Samsun to start nation struggle and served in the Ministry of Health and Prime Minister. After declaration of the Republic Minister of Health, Dr. Refik Saydam made great contributions in establishment of development in our country's health services during his ministry until 1937. In 1923, health services in our country were provided by government, municipality, and granted doctors and small health officers, 86 inpatient treatment institutions, 6,400 patient beds, and 554 physicians, and 96 pharmacologists, and less numbers of nurses, and etc. Today, approximately, if I'm not wrong, 200,000 doctors provided health service. The construction of 1928 of Hıfzı Müessesesi organization started in 1929 and continued until 1933. 1 year after its establishment, the amount of the serum produced the country's need without the need of any import. And I can talk about briefly, actually I don't want to take so much time, but I can say briefly about regarding the Hıfzı institution. During the 1933-1937, the production of rabies vaccine started, and in this period, tetanus, diphtheria serums to the Greek and Syria and to Iraq, and during the cholera plague in China. And cholera vaccine was sent to over 1 million people. That's a great success, I think, because they started from the zero. And it's great honor for us. Dear participants, reforms that happened with Foundation of Republic about the healthcare, today's health sector bases success in our country. Studies carried out under the coordination of our state, society's general healthcare to get better, and it makes a great contribution of living condition of daily life. Atatürk gave importance to training of health personnel in order to provide health services in accordance with the universal standards. The increasing number of medical faculty, big steps were taken to increase the quality of medical faculty. Ankara University Medical Faculty started the first medical faculty establishment during the Atatürk's time. Mustafa Kemal Atatürk made great revolution in the field of health in Turkey by increasing the accessibility and quality of health service. Thanks to his visionary leadership, Turkey created modern health system, and society turned into more careful about health. These settlements have enabled Turkey to make significant progress in the field of health and its citizens to have access to better health conditions. I would like to finish my speech with Atatürk's statements. Commend me to the Turkish doctors. Why? Because we trust them not only for their knowledge, but also their human sense. Thank you all for listening. Have a nice time. Have a nice symposium. I hope that it will be so fruitful symposium for all of us. Thank you very much.
Thank you, dear Professor Tur, and for your support during this symposium and being with us today. And next speaker will be Professor Dr. Recep Bozdoğan, who has already is our new coordinator of all our research application and centers. So the speech is yours, Professor Bozdoğan.
Thank you very much, dear Arta. Due to so many opening speeches, I will make a very short, fast welcome speech because the shorter may be the better. Dear speakers and honorable guests, first of all, I would like to greet you with respect. I would like to thank everyone who contributes to the organization of this symposium. We have a proverb in Turkish that health is the beginning of everything. This saying places health at the heart of human life. One of the main tools for protecting and promoting both social and individual welfare is health education. Distinguished academicians participating in this symposium from 9 different countries will make presentations on health education, health service, health policies, and treatment methods. I believe that the symposium will be beneficial to the accumulation of knowledge in these areas. The reference to the centenary of the Republic of Turkey increased the symbolic importance of this symposium. I congratulate dear Arta Feyzullah because of organizing this good event. As I end my words, I greet you all with respect. Thank you very much.
Thank you, dear Professor Bozdoğan, being with here today. And again, I think that I believe that we will do a great job in your new role as a coordinator. So thank you again for being part of this symposium and with us. Our next speaker, who contributed greatly to this realization of this symposium, is the İstanbul Aydin University Faculty of Health Sciences Dean, Professor Dr. Ayşegül KAPTANOÞLU. So, Professor KAPTANOÞLU, thank you for everything, and the speech is yours.
Thank you very much, dear outstanding and distinguished guests. We are very pleased to be with you in the early morning in this conference. And within the scope of this public health and health conference, I want to share that public health services began exactly 100 years ago with Atatürk, and we continue with the same vision of the new century of Turkey to project and improve public health. So our motto is Turkey living with health. We have been working to protect and improve public health within the same mission and enthusiasm for 100 years. And then we have done lots of and various public health carry out many screening programs against various genetic diseases, pandemics, for newborn and for adults and for family medicine system, which is strength and the number of healthy live centers is increased. And also Turkey is still going to again produce healthy vaccination program and carrying out many screening programs against various genetic and infectious diseases. So 100 years is in health services is very successful, and I want to share with you my topics about the Turkish financial and sustainable healthcare and clinical and public healthcare situation nowadays. Your voice is not coming, dear Arta.
Yes. Dear Professor KAPTANOİLU, I would like to offer my endless thanks to you because I felt your support in every situation and you were a source of inspiration to realize this symposium. So thank you again for being here, and then we will continue as a first speaker with your presentation. And now I'm going to invite İstanbul Aydin University Vice Rector and International Relations Director Professor Dr. Zafer Aslan, which is here with us. So the speech is yours, Professor Aslan.
Thank you, dear my colleague, Ms. Arda. Dear Chair, distinguished colleagues, it's a great opportunity for us to say welcome to the Symposium on Health and Education in the World and Turkey in the new century of the Republic. As we know very well that institutions, universities, all training institutions, they are all global leaders in education. They have top priority like UNESCO and also other educational institutions, because education is a basic human right and the foundation for peace and sustainable development. UNESCO is the United Nations specialized agency especially for education, providing global and regional leaderships to drive progresses, strengthening the capacity of national systems to serve all learners. Education has the power to transform life of children and young people, mainly in our universities and other universities and the world around them. But inclusive and transformative education cannot be delivered if students are not safe, are not healthy, and free from violence and discrimination. This strategy, revised and updated since its first iteration in 2016, presents UNESCO's vision for better health and education outcomes for all learners. As Dr. Tur and also our Dean, Professor KAPTANOİLU, mentioned about that the Mustafa Kemal Atatürk's great mission and vision about education, beginning from the Turkey republics. So even associated with these missions and visions, UNESCO work in collaboration with United Nations agencies, multilateral organizations, and civil society. They put health and well-being at the top of the education agenda. Maternal complications are the leading cause of the death among girls aged in between 15 and 19 years old. Violence in and around the school is experienced by 246 million learners every year, unfortunately. In addition to The COVID-19 pandemics highlighted the unmet need for mental health services in and around the learning institutions to achieve a vision where all learners can fulfill their potential. Like UNESCO and all education institutions, they support school systems that promote physical and mental health. Unfortunately, 73 million children live in extreme poverty, food insecurity, and hunger in our world. The UNESCO strategy on education for health and well-being was updated to extend its transformative vision to 2030 to achieve the Sustainable Development Goals. The revised strategy reaffirms the priorities of the previous one, as well as it focuses on mutually reinforcing intersections of education, health, and gender equality. In addition, it includes an expanded focus on strengthening the resiliency of school health systems and their ability to promote both physical and mental health and well-being of learners. A key milestone was in 1996 when UNESCO joined to UNICEF, UNDP, UNFPA, World Health Organization, and the World Bank as one of the founding co-sponsors of the United Nations joint programs. So, school systems, especially in sub-Saharan Africa, were particularly hard hit. In recent years, over 3 decades later, we are reminded of these difficulties as the world is confronted with another unprecedented global public health crisis. Global South is also, we really primarily should focus on the part of the world for health education in addition to climate changing and its served results. If you turn back again, the COVID-19 pandemic, which affected education sectors across all regions, leaving over 1 billion children, young people out of school for months. And studies estimated that over 5 million children around the world lost a parent or, unfortunately, other caregiver to COVID-19 in just the first 19 months of the pandemic alone. Joining forces with WHO, UNICEF, and other department partners, UNESCO, together with the universities and other educational institutions, worked quickly to make a crucial technical guidance available to ministries of education to guide their response. To reach learners directly during school closures, UNESCO also pioneered a range of practical materials, digital resources, and radio programs to help young people deal with anxiety, adapt to distance learning, and stay safety and healthy when returning to school. It is informed by the lessons learned of AIDS response as well as those of the COVID-19 pandemic. Not only the UNESCO, but also many institutions, universities, educational organizations like Organization Women in Science in the world, which is working under the umbrella of Third World Academy of Science. Our university, we are so proud that one part of this group, Turkish Action Group, we have ongoing activities embedded in this organization. They try to help the developing countries, especially the ladies at their early career stage. So we also consider the health promoting education systems integrate a comprehensive approach to school health and well-being as an integrated part of our daily missions. So we all agree with Mrs. Stefania Giannini. I would like to share some lines, which is declared by herself, who is the UNESCO Assistant Director of the General Education and Health Systems. And universities, all departments, to national education sectors and other key stakeholders to adopt a comprehensive approach to school health and well-being. This in turn will contribute to achievement of SDGs, particularly those at education, health, and gender equality. Fortunately, we are lucky. You know why? Our university has a great experience since 2003 together with the ongoing online education. So we all academics, admin staff, and students were easily be able to adopt the pandemic conditions and training programs. And we have still used the benefits and advantages of the advanced digital technologies, softwares, and so on. So with these feelings, finally, I would like to thank to the organizing committee, mainly to Assistant Professor Dr. Arta Hoca and the Director of the Applied Research Center, Dr. Thor, and also General Coordinator, Professor Bozda, and also Dean of Faculty of Health Sciences, Professor Ayşegül KAPTANOİLLU Hoca, and Dean of the Faculty of Medicine, and all the chairs and who helped to organize this important symposium, all the collaboratives, all participants, especially for the participants, presenters, for their valuable contributions. I'm sure outputs and final marks of the symposium will be very important on developing our future strategies related with health and education problems. With my best wish during 2 days and best regards. Thank you very much.
Thank you very much, Professor Aslan. I would like to express my deep gratitude and respect to you that you supported us in all of this time to realize this symposium, and already your team, international office, that helped us to find the partners, to get in contact with all of our dear esteemed guests that are going to be and to share their knowledge with us. So thank you again for being here and sharing your valuable time, and that you give us important information sharing with us today. Thank you again, and hope that it will be a very knowledgeful impact, fulfilled with knowledge and wisdom, this symposium. And the last speaker, our university rector, Professor Yadigar İzmirdi, would like to join us today, but she is not here today. And she would like just to convey her warm greetings and best wishes for the success of this symposium. And she thanks you for all being part of this remarkable gathering and for such an inspiring field, meaningful discussions, shared wisdom, and the promise of a healthier and a more educated world. So the message is like that. So now, dear professors and dear guests, thank you again for your speeches and being here with us. Now I will start with the distinguished speakers' presentations. But first of all, before starting for all of the speakers, at each time the speaker will start their presentation, I will give a short introduction about our speakers, that who are they, and about the education and the career. So our first speaker will be Professor Dr. Ayşegül KAPTANOİLLU. And before Professor's presentation, I would like to give a brief introduction about our first speaker. So I will share with you one presentation, just 1 minute. Share. Görünmüyor. Yes. Our first speaker today will be Professor Dr. Ayşegül KAPTANOİLLU, the Faculty of Health Sciences Dean of our university. So I'm going to the next slide. And when I introduce the first speaker, I would like to mention that Professor KAPTANOİLLU, after finishing high school in the Saint-Benoît French High School, she continued her Bachelor MD, in fact, studies in the Faculty of Medicine, Istanbul University. After completing the Faculty of Medicine, the professor's subspecialization is in the Family of Medicine in the Haydarpaşa Numi Training and Research Hospital. Of course, our professor works a lot. I think that beside the Faculty of Medicine and Family Medicine, the professor continued the bachelor degree in the finance department and then the master degree in the health institution management in the Marmara University, and then the PhD in the hospital management in the Marmara University. The professor's academic career started as an assistant professor in the Health and Management and Economics department in the Marmara University, but she continued the same after in the same university as an associate professor in the Family of Medicine, as a professor in the Health Management City University of London, and as a professor again at the Health Management for 5 years at the Trakya University, and then as a professor again at the Health Management department. And now, since 2021, Professor KAPTANOİLU is our professor in the Health Management department and the Faculty of Health Sciences in our university. Besides her current administrative duties of the professor, she is working as a dean in the Faculty of Health Sciences since 2021. The professor's research expertise is especially the health management and economy, medical education and training, medical ethics and history, and of course, a lot of other expertises that the professor is going to share with us today. So when we talk about the research productivity, I would like to share that the professor has over 1,000 citations that are already present in the Google Academic. So if you are interested or you would like to contact with the professor, you can contact with the professor in this manner if you are interested in the specific research fields. So thank you again for your valuable time and welcome to our symposium. And we are going to start with the first speaker, KAPTANOİLU, with the presentation. So now I'm stopping my sharing and the professor is going to share the presentation with us. Thank you again and welcome to our symposium. Professor KAPTANOİLU, we are not hearing your voice. Yes, Professor.
Could
And
you see
maybe-
the sustainable financing healthcare? If
Yes.
I will be able to, yeah,
We are-
okay.
Yes, but just can we do that a full screen, Professor?
Full screen, okay.
Yes.
Okay. I try to summarize the sustainable financing for healthcare during this 100 years, because making something sometimes is difficult, but making something sustainable is much more difficult than this. Everybody needs a strong umbrella for healthcare services, because if somebody have some sicknesses, illnesses of disease especially, they also need the strong umbrella of healthcare services, especially the governmental one, because we are a country and social health statute of country. And as we see, high income country, the country which are much more rich than us, are spending more than 20% of their global finance to health. Therefore, if we are not so rich, then we must find a way to make sustainable healthcare programs. We have done two reforms in healthcare program. One was in 1960s, and the other one was 20 years ago. And social insurance system 20 years ago became in one umbrella. All the SGK, SSK, and all kind of Bağkur and everything became one umbrella. And pension fund for civil servant, emekli sandığı also, became in only in one kind of founding. Our hospital were much more have diversity, like a teachers hospital, police hospital, railway workers, and so, university hospital. Nowadays, we only have a secondary care hospital and tertiary care hospital. And also we have a stronger family practice primary care center as well. Of course, we need lots of new pension and new funding methods for this. But the important is now, if somebody is seeking for their health services, they can found some kind of hospital and some kind of primary healthcare services, and they can reach easily their family practitioner. And especially the uninsured person, for example, widow, children, and close parent of the deceased are paid by governmental fund. And Bağkur, which are for the people who are making commerce, are also benefiting from the secondary and tertiary care hospital, like a craftsman, artisan, and small businessman, SME, and technical and professional people, and like a shareholder of company, cooperative, and self-employed in agriculture also could use Bağkur, can benefit from the every kind of hospital, even though they can go to tertiary care and secondary care hospital according to their illnesses and diseases. And for founding this kind of social insurance system, they do not need to pay too much. If they are working in a social security centers, or if they are working like emekli sandığı, some percent of their salary is enough for the sustainability of this healthcare system. Otherwise, all people in Turkey must pay for healthcare services. If someone doesn't pay for healthcare services, they cannot benefit from the healthcare services with their money. We cannot pay all kind of health services with money unless for private hospital, but all kind of private hospital are not enough for like a governmental hospital, public hospital, to cure our illnesses. So if we look from the public healthcare side, we have a strong primary healthcare services, and if we take care of the inlying bed healthcare center like a hospital, we have also very big and effective hospital in every city. And nowadays we do not need for green card system, because if somebody doesn't have money enough to pay this kind of founding healthcare system, then the government are paying with them with the having contact with the health authority like muhtar and kaymakam and so on. So even you are an immigrant or you are staying more than 6 months in Turkey, you must pay for our healthcare services in order to in order to reach all kind of health services, even for surgical health services and inlying bed internal health services and outpatient health services as well. It is very different compared with the American and European healthcare services, because if you don't have security, healthcare security in this kind of big country, in this kind of rich country, you cannot reach to their hospital healthcare services, and you cannot even reach their primary healthcare services as well. But if you stay in Turkey more than 6 months, you only go to the SGK and you are asking, how much do I pay here? And I am staying here more than 6 months. If you are a student or businessman or any kind of trade or education services, if you are benefiting this kind of services, then, and if you are staying then over than 6 months, we can have all kind of health services with paying some kind of not too much, only, for example, 10% of our salary, of our gain, And then we had very good healthcare services, and we do not need the prescription because in family care centers we can have our prescription as well. Red Crescent is a big humanitarian aid organization beginning from the Ottoman Empire until the Turkish Republic, and especially in earthquake and natural disaster, they are serving very good, valuable services. And only Red Crescent can have a blood donation in Turkey. No other center can have a blood donation, and this blood donation program is working very well. Some countries are trying to have a lesson from this universal health coverage, and this universal health coverage within 10 years achieved a big and notable improvement in health equity. And the first one was introduced in 1945, and the second one in 1960, and the last one in beginning of the millennium in Turkey. And the health transformation program in Turkey was a really very big and successful program, and therefore all kind of people, even they are rich or they are poor or nothing in between them, can reach easily to every kind of healthcare services easily. Only thing we couldn't make in usage the program that first of all we must go to family practice first, then secondary care and tertiary care. This kind of program is very common in United Kingdom, in England. And in England, people, first of all, they must go to their family physician, general practitioner, and then if they needed some kind of inlying services, if they must stay in the hospital, then secondary care, and going to tertiary care is very difficult in this kind of country. But in Turkey, this is not very difficult, even though we do have some problem with this access to tertiary healthcare services, but still we can cope and we can make sustainable this kind of health services, health coverage, because healthcare services always depend on some kind of how to say experimental and outsource of rich country health, because all kind of medication and all kind of health services are first of all discovered in the rich country, in Western country, then they are coming to other country in the especially in middle income country, United States, United Kingdom, Switzerland, Japan, Australia, and this kind of country are very rich for transforming and finding new drugs and new healthcare services, but still we can cope with this health coverage and services, and we do not have inequitable financing and shortage of inequitable distribution of our human resources. But the problem is making it sustainable, even though there are lots of big crises in the world, because health is a very important matter, and therefore we must find policy, we must try to make policy making, regulatory financing, and service provision role in the healthcare security and healthcare system. And we must find quality, very good quality healthcare system with not increasing but decreasing healthcare expenditure. If you look in Brazil, in China, and India, and Indonesia, they are really spending too high of their health expenditure. We are trying to decrease this person because it's not sustainable if you do it in a more than 10%. For example, in United States of America, it is very high, and people are trying to pay their healthcare insurance. Otherwise, if they are not paying, they cannot benefit from the hospital. But in Turkey, this is not a matter. So between during the 100 years, we have done lots of good policy making and sustainable policy making, and we need also to make even much more than this kind of policy making and find a money, find a benefit, find some kind of transfer to healthcare services and healthcare insurance as well. Especially in multi-crisis world, because we are living in a very difficult world with multi-crisis, pandemics, war problems, and still some kind of world war, like Ukrainian and Russian war. And this kind of problem are making very difficult to give sustainable health services to immigrant and as well as to our people. But we are still making primary healthcare services stronger, and we are strengthening emergency medical care services, ambulances, and so on. And we have enough medical faculty in order to graduate medical doctors. Also, we are trying new pharmacological health problems after this 100 years. And if we are trying, and if we are beginning successful in pharmaceutical industry, then Turkey will be a really very good star in their geographical area. And we need to achieve this hard program in order to make sustainable health transformation program in Turkey. So health transformation program is collaborated with agency including the World Bank, World Health Organization, and Organization for Economic Cooperation and Development. United Kingdom also has done the same program at the same time with Turkey in England, but Turkey became much more successful when we compare to United Kingdom, because in United Kingdom also there are lots of immigrant problem, and they are paying all kind of health services from tax. Only the big difference between United Kingdom and Turkey is referring system. Referring system in Turkey didn't work because United Kingdom began to do this referring system at least 15 years ago, and we have been late, like Belgium and some kind of European country. So therefore, Turkish people doesn't want to go family practice. First of all, if they have some kind of problem, they just go to the hospital, and this kind of financing is making hard to run the hospital. So if in comparing with the United States, Germany, England, Turkey are spending less money than the other one, because in our system we are trying to make our operation and theater room equipment in Turkey. And if we are trying to make lots of pharmaceutical drugs in Turkey also, it will be very good to Turkey also for providing affordable and quality healthcare services, and also for financing them. Dramatically, the children and mother and adolescent and mental health are affected very good condition comparing to the beginning of the 100 years ago. And now we only need to find new way to driving economic growth and reduce poverty and reduce child mortality and maternal mortality and improving high fertility and adolescent and coping with the adolescent and mental and neurological problems. Because if you are really managing pandemics and cardiovascular diseases and cancer problem, then you need to manage mental and neurological problem. Because of these earthquakes, there are also some cancerogenic agent around the world and around also our country, asbestosis, and we must keep close attention this kind of problem also. And that's a I'll try to summarize the Turkey way during these 100 years, and I try to demonstrate that Turkey is very successful in healthcare services. If you have any question, we will have a discussion with the audience.
Dear Professor KAPTANOİLU, thank you very much for your presentation and your time being here. And now, if our participant and guest have a question, you can write here in the chat box. And while waiting, I'm also receiving the questions from the class, because we have two classes of the student. They are attending the symposium from the class, and they are going to send their questions from to my mobile phone that already watched your presentation. So let's wait a little bit for the question. And yes, one of the students that sent a message to me is this one professor. They said that how do the global health crises such as pandemics impact the sustainability of healthcare financing? And what strategies can be developed to mitigate these effects?
Yeah,
so
it's a very good question. Thank you to our student. It's a very clever question as well. So what we can do, we must change the habits of the people by making social mobilization campaign. Making social mobilization campaign is not easy, and changing behavior is not easy, but the first duty of the physician and the healthcare services providers and nurses is trying to show people that their habits are their destiny. Because if we are not going to bed in the time, if you are not eating enough good products like carbohydrate and proteins, and if you are not vegetables, and if you are not drinking enough fruit and water, then it is very obvious that we will have a lot of problem with health. So beginning of the primary school and also beginning of the kids maternal school, we must try to change the habits of the kids, and the physician first duty is also change their habits. Then people will try to look to your habits, because people always are affected and influenced with the teachers and with the physician, with the nurses, and with the healthcare services providers. Therefore, first of all, we must, for changing our destiny, we must change our habits. This is the first public health situation.
Okay, thanks, Professor, a lot. And there is another question that already is at me now. They ask that what are the potential benefits and drawbacks of public and private partnership in healthcare financing? And how can they be optimized for long-term sustainability? So public and private partnership in healthcare. What are these benefits and drawbacks?
This benefit is in some country, private company are much rich than government. For example, in United States of America, as we know, for example, Apple and the other country business maker are richer than any kind of country. Therefore, if these people want to make a collaboration in public-private partnership, it will be easy unless if we use a social security. In social security, people must learn that they must pay for their health, even they are healthy. Beginning of their young ages, if people give enough money for their health security system, for their health insurance, and in any case, if they will have a problem with their health, and if they have some kind of unattended position, then this health insurance system will help them. And also this kind of health insurance system, like a public-private partnership, will make lots of area for young people to work inside also. For example, in public-private partnership, we have a good hospital and we have a good insurance system, and the people will try to find a new job in this kind of health system. Otherwise, if only we wait only from taxes, we couldn't be able to have immediate and enough healthcare services in every part of the world.
Exactly. Yes, Professor. Thank you. And the students are hearing there. And we have one question from the chat box here. Maybe you can also check there, but I can read from here. And the Professor Dennis said that, "Dear Professor, thank you very much for your presentation. My question about your topic is, how does the quality of education in Turkey compare to global standards, and what strategies can be implemented to enhance especially education quality and accessibility?" It's a question much more related with the education quality. In fact, a little bit different, but
yes, I'm not very keen on all kind of education, but I can understand on the medical and health care, health sciences education. And if we are comparing us with the other country that I have been able to be in the education practice inside, especially United Kingdom and United States, and because of my close friend Japan and so, and Turkey, education in health sciences and medicine is not in a bad condition, is in condition of the worldwide. But the thing is, teacher must try to cooperate with student, and student also must cooperate with their teachers, and they mustn't try only to have only with diploma, but as far as I see in the world also, nowadays people only are trying to have a diploma, and that's all. And the thing is, for finding good teacher in all over the world, we must we must give performance to people. If we go if we give same performance to every part of the world, people won't try and won't make education much more better. So performance system like Singapore will make health education better, as far as I concerned about it. If everybody had the same salary, same for even for the in a medical side and physician and in nursing side and other side also, it wouldn't work. So we must try to find performance system, and we must run with performance system, education system like Singapore, and that will be easy to understand this.
Yes, Professor. Thanks a lot also for giving information about the education system, even it was much more related with the global health issues and policies. So I'm just waiting for more. Is there any question as we have time for the next speaker? Yes, dear guest, do you have another question? If you would like, you can write your question at the chat box. Oh, there is a question from another professor that said that I would like to thank for your valuable question and ask a question again for your how can low and middle income countries develop sustainable financing models for their healthcare system to ensure universal health coverage? There is another question on the chat box. Maybe you can check it, Professor.
Yeah, okay. The way is very simple. It has been found also 100 years ago by Mustafa Kemal Atatürk and Refik Saydam and their friends. First of all, we must use primary healthcare services, public healthcare services, and also maternal healthcare services. If maternal healthcare services is good, if the maternal nurses and midwife and people working in the public health having good opportunity, and nobody asks this kind of people, which kind of specialty do you have? The big problem in medical school postgraduate is always we are asking physician, which specialty do you have? We never ask a teacher, which specialty do you have? We never ask other kind of people or lawyers, which specialty do you have? But we always ask a physician, which specialty do you have? Therefore, people will learn that primary healthcare services, general healthcare practice, and nursing healthcare practice, midwifery healthcare practice, and especially healthcare practice done by some kind of teacher in primary school and before primary school for changing healthcare habits, and every kind of this animation on TV, on this kind of animation on cinema and movie, and so they will understand better to have to choose problems in low-income country. Otherwise, in low-income country, people cannot afford to cope with a cancer problem, oncological problem, and also cardiovascular problem, because they are too more expensive for them. Therefore, to having some kind of this chronic problem we call diseases is most of all 100% is because of our habits. We must change our habits if we are living in a low-income country. We mustn't look and watch the rich countries movie. We must have a low-income countries movie. For example, we were eating bulgur wheat before. Nowadays, we are trying to eat snacks and not healthy snacks like a hamburger and so. And because we are really fancying to eat this kind of meals, our children also wants to eat them. Therefore, I know lots of mothers, they are eating this kind of snack and try to make to their children spinach and vegetables and so. And always I'm saying that never your child will eat vegetables and so, because you are not eating with them. And also, we are not eating with kids and we are trying to feed them, and then we are trying to go to bed them. After putting them to the bed, we are trying to feed ourselves. The kids and children never forget about what you are doing. Therefore, if our destiny is to born in a low-income country, then we must change our behavior. If we don't change our behavior, our destiny will be with us, and always trying to making bigger and bigger hospital will not choose our healthcare services. So therefore, I really appreciate 100 years ago, Refik Saydam and their friends and Atatürk attitude on healthcare services, for especially primary healthcare services. We mustn't forget about this.
Exactly, Professor. We don't need to forget that. And thank you. We have a lot of questions here, and already the person already thanked about that. And I think that we are on time. So thank you again for your presentation, giving us such a fulfilled information about the healthcare system and even for the education system, quality of that, and for others topics. So thank you again for your presentation, Professor. And now we are going to continue with our another speaker. Thank you again, Professor. Now our next speaker, normally in this program will be Nina PEREZA from the University of Rijeka, but just Nina already sent a message because of some health issue. She could not attend now the symposium. So we are going with our next speaker, Professor Dr. Ullah, School of Pharmacy from the University of Management and Technology from Pakistan. And the professor is going to talk about the challenges and opportunities for health education in the current higher education environment. Before professor presentation, I would like to give an information about the professor. Of course, the professor is going to mention about everything better, but just for the audience, I would like to give a brief information for the professor. So our next speaker would be Professor Cheema, and the professor already completed in 2002 the School of Pharmacy in the Pakistan, the pharmacology department in the pharmacy. And the professor has a master's degree in pharmaceutical services and medicine control from the University of Bradford, UK, and already has an overseas pharmacy assessment program from Aston University. And the professor completed a PhD program in the pharmacy practice from the University of Warwick, UK. And in the academic career, of course, if I forget something to mention, I will require from the professor to add much more information if it's needed. The academic career finished the bachelor, master, and PhD, and worked for 10 years in the UK as a pharmacist and pharmacy manager. After that, the professor continued working as a professor in the University of Birmingham, UK in 2018 and 2021 as a program director. And then again, at the same years in the University of Warwick, external member of the Warwick Evidence. Now the professor since 2021 is working as a professor at the School of Pharmacy, University of Management and Technology, Pakistan. And now the professor already continue a current administrative duty in the University of Management and Technology as the founding dean of this university since 2021. When we check about the research expertise, we see that the professor has an expertise especially on the clinical pharmacology, pharmacy, and the practice, and do research design and research articles in this field. And when we check about the research productivity, we can check that the professor has over 952 citations in this area of the focus. So I would like to thank the professor that accepted our invitation to be a speaker in this symposium, and I would like to welcome to our symposium the Professor Cheema. So yes, Professor, And now is your time, and thank you for being here with us.
Thank you very much, Professor Dr. Arta. Can I share the screen now? Am I the
Yes,
host?
Professor, I made you a co-host so you can share your screen.
Okay. You can see the screen?
Yes, Professor, you can make it a full screen. And of course, if I miss any information, you can add about that. And thank you again, and the stage is yours.
Thank you very much once again. First of all, I would like to congratulate the Republic of Turkey for celebrating the 100 years. So a big congratulations from on behalf of Pakistan, actually. Also, I would like to say the commendment to the organizers at the University of Aydin, and also Professor Arta and your team for organizing this excellent symposium on the topic of education and health in the world and Turkey. So, and also for the generous introduction. To be honest, I'm really thankful and humbled to be here. So what I'll do is in the next probably 20 minutes or so, I would try to sort of summarize some of the challenges as well as the opportunities for health education, because as you mentioned in my intro, that primarily I'm an academic with a pharmacy background. So I have a mix of professional and academic experience. And since for the last 8-9 years, I'm purely an academic. So I'll share some of what I believe my perception is about the challenges. So first of all, let me get this disclosure out of the way. I have no financial relationship to disclose. I would not be discussing any sort of off-label or investigational use of any medicines or interventions or products. So as I mentioned at the start, that this presentation is about sort of highlighting briefly the challenges and opportunities. You probably would notice, dear members of the audience, students, as well as my colleagues in academia and practice in various healthcare fields, is that I've grouped these challenges and opportunities in one sort of bullet point. And I feel that I've done it intentionally, because I always feel that wherever we mention the word challenge, it's always an opportunity at the same time. So I just thought while we are discussing the challenges, we should also keep in mind that with every challenge, there is an opportunity. And then probably I will sum up towards the end. And if you have any questions, feel free to put it in the chat box. And also I'll leave my email. So any question, if I couldn't answer here to your satisfaction, I will get back to you. So let us just first of all spend few minutes actually trying to look at the global perspective. Again, this presentation is not specific to Pakistan. I have tried to sort of put certain perspectives from globally, from the academic institutions, as well as the practice of health globally. So probably the first thing, and actually it's not like in a sequence, but what I thought was something which I felt was in a priority was that you would appreciate in the last probably few, I would say in the last 5 years or probably more, that there have been emergence of artificial intelligence tools, machine learning, and these fascinating AI tools, big data machine learning tools, and that sort of has started to revolutionize the healthcare industry across the world. I'm talking about the developed countries, and also it is impacting even the developing countries and probably the underdeveloped countries. while it is offering numerous opportunities in terms of making the diagnosis appropriately, also making the analyzing big data sets. So it is something which probably is a bit of a challenge also, because we in academic institutions, whether we are imparting medical education or pharmacy education or nursing or allied professions, we also need to bear in mind that our graduates need to be equipped with these tools. Our curricula needs to be transformed to ensure that our graduates, when they graduate, they know how to make use of these tools so that they can do the decision making precisely. The second thing which I thought would be useful to keep in mind, because of course we have just sort of recovered, the whole world has recovered, thankfully, to the innovative vaccination program that the whole world's witnessed the horrible outbreak of COVID-19, and this probably was one of the largest pandemics which sort of engulfed the whole world, and probably that should sort of trigger in our minds, in our respective healthcare institutions, that how to prepare our graduates in terms of imparting the knowledge, giving them the opportunities to make them aware of how to cope with these challenges. Because of, God forbid, if something was to sort of emerge in the next few years, are we equipped in terms of not only as healthcare institutions, but also as academic institutions? Do we have the equipped workforce that can sort of cope with these outbreaks, and how they can sort of deliver this quality care? The third thing which is probably relevant, and in this I would say has been going on for more than a decade actually, is the advances in the genomics. When we say genomics, it's about the data sequencing and genomic testing. And why it has been happening is because of the sort of priority of the healthcare authorities in Europe, in US, as to how they can come up and treat patients on a personalized and patient-centered care, and how this data sequencing can be used to deliver personalized medicines for patients. So perhaps this is something which we also need to start sort of integrating in our curriculums, if we haven't done it already, that how we can best equip our students so that when they graduate, they have the enough competencies in terms of delivering this personalized medicines. Probably another thing which has sort of impacted the health landscape is the promotion of preventative healthcare, and that's sort of something which my previous respected professor was also mentioning, something about the promotion of the lifestyle changes, about the priorities in terms of our eating habits, in terms of our lifestyle, the importance of exercise, the health promotion campaigns, and all that sort of thing is basically has become a priority for the healthcare authorities, that if we have to combat these challenges, these various ailments, how best we can combat, because we cannot keep putting strain of these different challenges, healthcare challenges, on our respective healthcare bodies. And of course, we sort of need to plan and have certain preventative measures in place, and that's where this preventative healthcare has sort of taken an extreme significance. And this is also something which we need to bear in mind in terms of when we talk about preparing our graduates, how we can best prepare them. Then probably another thing which to be honest, I'm personally a bit biased towards, so allow me to express my bias on certain areas, and this is something which I take extreme weightage, I would say, is about the ethics-based practice. I know that most of you would appreciate that this is something which is going on. It is something a given. Every healthcare professional, every healthcare institution should sort of deliver their teaching as per the ethical models. We as healthcare professionals should always practice ethics-based. But why am I putting this as one of the priority points, being as an academic, is because of, if you relate this to the first point, which is the artificial intelligence and machine learning, because you appreciate that while it is offering enormous opportunities for the healthcare providers and healthcare institutions and healthcare authorities and prescribers, again, it is going to question our practice of ethics to some extent. So that's something which we need to not only teach our future graduates or current students as to how to make use of these tools, but how to ethically use them, and probably re-emphasize the point of practicing on the international and modern ethical practices. I'm sure my colleagues in academia, in medicine and other healthcare professionals would recall the ethical biomedical principles of ethics, you know, the autonomy, the beneficence, the non-maleficence, the respect, and all these values have importance. And when we are talking about the patient-centered care, which I've listed at the end on this screen, it is about making sure that we respect those ethical principles and deliver our quality care and care on the terms of the ethical models. And also, when we are preparing our graduates, they need to be fully prepared in terms of how to deal with various complex patients, how to deal with various ethical dilemmas. What about if there is patient confidentiality being compromised? So all this should be integrated in our curriculums, and we should be making sure that our graduates are not only competent but also ethically practicing. And the other thing which probably would I've listed here is the multidisciplinary healthcare, and that again I will touch upon this in the next few slides, is when we are talking about this delivery of patient-centered care, we are talking about battling this outbreak of infectious diseases such as another sort of version, God forbid, of COVID-19. Again, the healthcare now needs to is not something like is not something which can be delivered in isolation, and it has to be a multidisciplinary model of healthcare. So let's just quickly touch upon some of the challenges, and again I would try to bring the opportunities. Firstly, you would probably appreciate that in most of the healthcare, most of the healthcare authorities are struggling to sort of have the enough healthcare workforce. Of course, there are certain financial probably issues, the migration of people, the brain drain. We are running short of qualified and competent healthcare professionals, especially in certain areas of practice. I will probably mention, for example, in medicine, in nursing. These are some of the probably two areas, because as I mentioned at the start, I've practiced in the UK for 11 years, and I know that how difficult it is for the National Health Service to sort of have enough healthcare professionals, enough qualified healthcare professionals to serve in all these underprivileged and rural areas of the country, and same is the case with other parts of the world. So healthcare institutions like us and like yours, we need to sort of address this by by promoting healthcare profession or health profession actually. Again, I'm not singling out one particular health profession, but what I mean is that we need to sort of incentivize and promote the profession so that the students get attracted and we have the desired number of healthcare professionals so that they can meet the needs of the local as well as the international healthcare needs. So that I thought is one of the challenges. The other thing which probably I would have a quick glance is that as you appreciate that the health profession itself, whether it's the pharmacy or medicine or nursing or physiotherapy or other professions, it is not theory-based. It is actually a skill-based profession. It is all about how you have the hands-on experience in delivering the patient care. So it all heavily relies on the experiential learning. And when I say the word experiential learning, it's about giving them the exposure in real settings by providing them the appropriate clinical placements and so that they have the real taste in the real settings, and then they can actually sort of have the enough competence to deliver the care when they actually graduate. But you would probably appreciate that with the limited number of clinical placements available in globally, it is something which we need to bear in mind. I will talk about this in current scenario in Pakistan. We do have a limitation that we have for example, in our other allied programs, we have an issue where we don't have enough hospital placements to place those students and give them the exposure. So how we combat this? And probably my humble suggestion is that we need to forge and collaborate with the hospitals, with the primary healthcare centers, community pharmacies, and have these collaborations. The more collaborations we have, the better it would be. But again, I would say it still remains a challenge as to how we have the enough and adequate numbers of placements. Now, other thing which I probably would feel mentioning or worth mentioning is something which is about to cater for the diverse learning needs of students. As you appreciate, my colleagues, that we as students have various capabilities. We do not learn in the same style. We do not have the same sort of mental capacity to absorb various things. We have to have a certain sort of tailor-made delivery or tailor-made instruction so that we cater for various sort of learning difficulties and various sort of needs of the students. So I thought it's worth mentioning because sometimes we as academics sort of skip this and we feel that we are providing inclusive education but we are ignoring the fact that in our audience we might have some students who may have a certain difficult level of understanding. So I feel that as educators, as academic institution, we need to adjust our instructional methods and perhaps make them as tailor-made. When we talk about the patient-centered care, we also need to have a personalized student learning. So it is by providing prompt feedback, regular feedback, also about engaging them in small group teachings, SGTs, where typically you have 10 to 14 students. And this probably would give them a chance to sort of open up and you have one-to-one interaction with those students. Now, another thing which probably we feel, and it is something being an administrator of my current institution, and perhaps my peers and my fellow colleagues would probably have some sort of endorsement to this challenge, is how we go about in ensuring that we attract suitably qualified faculty and not only suitably, not only attract them or not only hire them, but we also make sure that they remain part of your academic journey or your institution. They remain, you retain them basically, and how you go about it, because in this evolving world, we have enormous opportunities. We talked about this in the couple of slides ago, that previously, that we have shortage of healthcare workforce, but we also need to talk about the issue of suitably qualified faculty. And I feel that by continuously engaging them, by continuously providing them the CPD, which is the continuous professional development programs, by mentoring them, by giving them the suitable reward policy, and the remuneration and the salary packages, they need to be attractive so that we continue to deliver quality education to our students. Now, something which probably, if you allow me just to spend probably 2 minutes, I know that I'm already approaching my slotted time, so just apologies in advance. This is something which I felt was necessary, and I know that probably this typically I'm talking about the objective structured clinical examination. Colleagues, if we are to sort of equip our students and graduates with various competencies to meet all those challenges in the evolving health landscape, which I mentioned in the first slide, we need to bear in mind that how we go about in assessing those skills, how we go about in ensuring that they are not only clinically sound, but also professionally sound. They have the right communication skills, they have the right problem-solving skills, they can work as a team, they can communicate with other healthcare professionals. So do we feel that the traditional MCQs and the short questions and the typically writing questions and essays, is it valid and robust in ensuring that we are gauging their competencies? So I felt this is something for those who already know this, so apologies for repeating this, but for the students, it is about objective structured clinical examination. It is based on in sort of a round format, sorry, in a systematic way, where the students are exposed to different settings, where they have to sometimes solve a prescription related issue, they have to deal with a complex patient, they have to speak to the prescriber to change the dose, and also they might have to perform a certain procedure. All this in a limited period of time, probably in 7 to 8 minutes. You assess them and you objectively mark them using a standardized checklist. So it has been actually in practice for the last, probably I would say, going back 50 years now, firstly in 1975. So I probably would skip this slide because it is something which is sort of self-explanatory, as I mentioned in the previous slides. Now, the other thing before we sort of come to the conclusion is about the interprofessional collaborations. As I mentioned in the first slide, when it's not about the doctors providing healthcare in isolation, it's not about pharmacists doing everything on their own, it's not about nurses doing this, it's all about multidisciplinary healthcare teams. The challenges are so enormous that we cannot work in isolation and we have to work collaboratively. So how we inculcate this practice and this culture of collaborating with other fellow professionals is through the interprofessional education, IPEs. This is something which I have been an active part in at the University of Birmingham, where I was sort of regularly arranging these sessions together with my colleagues in medicine and nursing and dentistry, is that we bring together the students from various disciplines, make them sit in a lecture hall or a theater, and give them some scenarios and make them sit together on one table with various disciplines, health disciplines, and ask them to solve a sort of a patient case. why we are doing this is because we want to bridge this communication gap. We want to break those barriers. We want to mingle them, make them as part of team, understand each other's roles, so that when they graduate, they know that pharmacist does this. A medical doctor is responsible for doing this, and same is the case with nursing and other colleagues. So again, this is something which I don't need to really talk in detail. I've mentioned this previously, is about the rise of preventative healthcare and how we sort of teach our students, or how we focus this in the as academic institutions. Now, this is something which probably I've already touched upon, that the emergence of all these AI tools and these innovative learning tools and innovative technologies, and the personalized medicines, the genomics, all this needs to be integrated in our curriculums. I know it would be a challenge, but this is something which, if we haven't sort of paid attention yet, we need to start focusing on this, how we introduce these specialized courses, or you call them as electives or minor courses in various these various AI tools, so that our students not only have the respective knowledge of their discipline, but also have these awareness of these technologies. So I felt this is something which is important. So I think probably this is sort of bringing my talk to close. What I've mentioned in the last probably 25 minutes or so is that we started by having a sort of background in mind, or certain things to bear in mind about the evolution in the health landscape. We talked about the challenges in terms of the emergence of pandemics. We talked about the emergence of all these fascinating tools. We re-emphasized the importance of ethics-based practice and ethics-based teaching. We emphasized about the multidisciplinary collaborations, and how we are confronted with various challenges, the issue of faculty recruitment, the issue of clinical placements. So all this sort of summarizes that the health profession has evolved significantly. And you never know when we have an opportunity in probably 5 years' time or 10 years' time to have to come across again in these sort of symposiums. We might be talking about something quite different to what we are talking about today. So because every minute we are witnessing a new innovation. So this is, yes, it is exciting time. It is sometimes a bit fearsome, and I wouldn't use the word panicking, but it's something which we need to be on our toes. When we say we talk about the academic institutions, and we have to have the evolution in our curriculums. That's something which I would leave it to the thought of my colleagues in the audience. So with this, I would this is just my references which I used in terms of OSCEs, and I've also left this screen. I will leave the screen actually on for my colleagues if they wish to contact me for any questions which I couldn't answer now. Please feel free to fire your question through the email. So with this, I would like to thank once again the organizers, and if you have any questions, I'm open to the questions. Thank you.
Dear Professor Cheema, thank you very much for your time, because as you are a dean, I know that it's not easy to find time for such presentation, but you reply every time and you help support us in this symposium. The things that you mentioned are very important, because also we have some challenges, the same one, I think, in all countries, maybe the increase of the number, clinical placement, and of course, as the technology is evolving. So you mentioned already, I just would like to ask something. What about the PhD or master studies students? Because you mentioned about the genomics and the personalized medicine, you know, pharmacogenomics, you know better, because as you are a pharmacist. What is the situation in this manner? How you found your PhD students? Can they achieve this, or can they have a chance to work in this technology, especially next generation sequencing, pharmacogenomics? What about the situation in this manner?
Yeah, thank you very much, Professor Arta. So, to be honest, you have asked a very valid question in terms of offering research in these specialized areas. And to be honest, my frank answer would be that no, we don't have enough expertise at the moment, to be honest. I mean, we sometimes are pondering on the fact that when we talk about sort of reforming our curriculums, but do we have the enough trained faculty to actually deliver these specialized courses at the undergraduate level? So, I mean, talking about research is something which to be honest, it is something which unfortunately we don't have the enough sort of capacities. But also, I would also mention the fact that by raising this and again raising these sort of research areas, we need to create awareness among our future researchers and also our MPhil or MS or PhD students, because what happens is typically that they are confined to certain traditional areas of research. And again, probably the supervisors are sort of comfortable in those specific research areas, and we are not sort of we are not challenging ourselves in these specialized areas. So, to be honest, I would humbly sort of regret to say that unfortunately, it is something which we need to put a focus on. We need to promote these research areas and also have first of all, develop our sort of competencies and start doing research in ourselves so that we can offer these areas to our students. So it is something in evolution stage.
Yes, exactly. It's the same already for all over, I think, especially for specific fields, because the technology is in a very high speed development, like artificial intelligence and also other fields. So to teach our students already to have a high quality experience in these areas, not an easy one, but maybe in how and no collaboration with other universities, it can be possible. And of course, Pakistan is, for me, has a very important place, because we have, as a university, we have an international delightful program, a short-term study programs. Maybe you have heard about that. And we had a lot of students, 40, for 10 years, over 10 years here, that come from Pakistan here for special courses. It's an intensive program for 10 days. So I know the students, they are very good qualified students that I see from now, because I had some of my students that were in my course, genetics and biotechnology course. So I'm aware about that, and about that, having chance to take such opportunity to go to these short-term study programs or abroad. So thank you again, Professor, and I would like to check now in the chat box that if the participant had some question related with that. And one professor has a question, maybe you can check also there. And they ask to you that, dear Professor, first I would like to thank you for this effective presentation. I have a question about the effects of latest development on healthcare, especially for higher education institutions. How have recent advances in healthcare technology and practices impacted the curriculum and pedagogy of health education in higher education institutions? In fact, you already mentioned about that, but maybe you can add something related to this question.
Thank you very much to my colleague for asking this question. To be honest, I would go back and share my experience from UK, because as you mentioned at the beginning, that I've just been to the University of Management Technology for the last 2 years. Previously, I was working as a program director. So what I would say is that I wouldn't say that it is directly answering your question about the advancements in the technology, but what I would say is, for example, in the UK, we of course had we still have the issue of qualified medical practitioners, and the National Health Service actually rigorously promoted the pharmacists to actually pursue the prescribing courses and give them the prescribing authority to actually prescribe in areas of competencies within their areas of clinical competence. So it goes back, and actually what we did was which I was sort of some part in the design of the curriculum, is that all the standards of the program would change in terms of giving them in terms of changing the curriculum. So the simple answer to this question is that it basically necessitates all these advancements, whether it's the issue of giving them the prescribing rights, whether it's the issue of the impact of these technological advancements. We in academic institutions need to be one step ahead and transform our curriculums. And this is something which we have an obligation to do so. And this is something which can only be done or can only be achieved by doing sort of a semester-wise review of the curriculums to ensure that, as I said, that the technology is rapidly advancing. So we cannot really catch up and cope up with these fast developments in the technology. So it should be, the curriculum review should be done, at least a minor review should be done on a semester-wise basis, and probably a major revision in 2 years' time, and go back and see whether the competencies are being sort of being equipped to the students, and also they are being assessed accurately. So I would endorse your question, and this is something which academic institutions need to bear in mind.
Thank you, Professor. And there is one more question here.
Sure.
Thank you very much for your contribution today. And what do you think about how emerging global health issues such as pandemics, as climate change, will influence the content and priorities of health education programs in higher education? Another one from another professor.
Yes, thank you. I think also this is something which is quite valid question. I mentioned briefly about the emergence of pandemics and how we and the rise of preventative healthcare, because of course our students, our graduates need to be aware of these challenges which they are going to face in probably a few years' time when they graduate. So focusing on these preventative healthcare campaigns, giving them the opportunities to be part of these running these campaigns, actually, so that they actually learn in real settings. And also the importance of sort of keeping your of course having the healthy eating, healthy lifestyle. All these promotional sort of campaigns need to be made compulsory part of the healthcare programs, and giving the students the exposure to sort of go about and be part of these campaigns. And I'm sure whether this is climate change or the pandemics, whether it's the issue of mental health, whether it's about of course making sure the healthcare professionals themselves are mentally fit, and also they have the appropriate health themselves to be able to face these challenges. So I think this has a huge impact, and the academic institutions need to bear this in mind.
Thank you, Professor. And I'm checking again. And here we do not have, but we have a question from one student from the class that are on place there. What strategies can be employed to evaluate the effectiveness of health education programs, they say, and to ensure that the graduates are prepared for real-world healthcare challenges?
Okay, I think probably what I would try to answer this question in a way that probably would also answer the previous questions, because I feel that the the continuous sort of quality improvement, which we call as CQI. The continuous quality improvement, CQI, is about making sure that your curriculums are robust enough, and they are preparing our graduates with all those competencies. So the only way we can gauge the performance of our graduates and making sure that they are fit to deliver all these campaigns or all these extended competencies, or making sure that they can combat with the climate impacts and also the technology advancements, is by asking the employers, by doing these sort of going back to the employers where our graduates are being employed. This is what I feel is that, yes, we as academic institutions can have all these innovative assessment methods. I mentioned about the OSCEs, the Objective Structured Clinical Examination, where you can assess those skills. But I feel that it's not something which we can actually be satisfied. The only way they can be tested in real settings is that when they graduate and they start working in the real market, after 2 years, you contact and do these collect the feedback from the employers, whether they are actually delivering all these extended roles, or do you need to make any changes in your curriculum. So, I mean, probably that is something which my respected student was asking, in terms of how you go about in ensuring that your curriculum is delivering what it should be delivering.
Exactly.
So it's not just about your in-house assessments. It's also asking the placement providers for the on-job assessments. It's about gathering their feedback and making sure that they not only have the degree, but also they are competent enough to deliver those roles.
Thank you, Professor, for answering and for giving such a valuable information. I think that we are on time and there is no any question. And yes.
May I just add quickly before we sort of conclude, is that you mentioned about the exchange programs and how we can actually learn from each other's experiences. And probably I would take this opportunity to actually invite you and your colleagues and the students in your audience, is that you can visit us. You can have to sort of have the experience of learning in a bit of in a sort of diverse learning environments. And likewise, we can sort of have an exchange program for students and faculty where we can actually learn from each other's experiences. So we are always welcome, and we extend a warm welcome to all your students and colleagues.
Thank you very much. We will be honored for this invitation, and of course to welcome you here face to face. It will be better to contribute to talk about what we can do to collaborate with each other, and which aspect, and especially in the student exchange programs. And thank you, Professor, again for sharing your valuable time with us and this information. And now we are going to continue with another speaker, which is the next turn. Thank you again, Professor, being with us today.
Thank you very much. Thank you.
With high respect, yes. Thank you.
Thank you.
Yes. We would like to thank again Professor Cheema. And now the turn is to Professor Dr. Monica Gulati from the Lowell Professional University. And before that, I again would like to share a very short information about our professor. And if I have something that I forget, and I would like from the professor to share with us or to add any more information. So our professor has in fact more than 25 years of teaching, research, and administrative experience, where already has an bachelor pharmacy from the School of Pharmacy, and where continues the same programs in the master and PhD degree. And the current administrative duty of Dr. Monica is the Executive Dean of the Faculty of Pharmaceutical Sciences since 2004 in her university in India. And when we check about the research expertise, we see that the professor has an experience in pharmaceutics, drug formulation development, and control drug delivery. So when we check about the research productivity, besides her busy administrative duties, the professor has a high age index and over 4,094 citations. So I would like to thank Professor for being here today with us, and welcome again to our symposium. And the speech is yours, Professor Gulati. I'm stopping my sharing, so now you are a co-host and you have the right to share now your presentation. Welcome, Professor, again.
Thank you, Dr. Armani. Thank you so much.
Thank you,
such
Professor.
Kind introduction. So I would just give me a moment so that I can share
Yes,
my
of course.
presentation.
We have time, Professor.
Yeah.
You can make a full screen, Professor. It will be better. Yes.
Yeah.
Thank you.
Is it visible now?
Yes, it's visible.
So, first of all, good afternoon to all the audience. And I am going to speak on, all of us have by now understood the side effects and the deleterious effects of all the drugs. We say that, any drug which is effective is going to obviously have some side effects, you see. So we're going to talk about the non-pharmacological treatments for various diseases. And basically, the magic lies in the gut. So as many of you might be knowing, there are a large number of microorganisms which are resident in our gut, right from, the mouth, the saliva, the mouth, up to the last part, that is rectum, colon and rectum. So these bacteria, these fungi, these viruses, so we say it is a complete microbiome in which we have a bacteriome, we have a virome, we have a fungome. So all of them have their own environment. And in fact, the role of gut microbiota was identified by the medical people. We still take the Hippocrates oath. So that it was identified by Hippocrates as early as 400 BC that, the major location of all the diseases, whether they are the diseases of the mind, they are the diseases of the skin, or they are the diseases of the GI itself, they lie in the intestine. So you see, these people were so knowledgeable that in 400 BC only he was able to predict this. So then we come to the very interesting term, which is dysbiosis. Now, as we all know, biosis is basically an environment. So biosis, when we are talking about intestinal biosis, we are talking about the equilibrium between amongst various bacteria, fungi, viruses, helminths inside the gut. Again, starting right from our mouth, going up to the colon. So we, when a baby is born, earlier people used to think that the gut of a baby is sterile, which actually proved to be a misconception. So when the babies are born, right at the time of their birth, their microbiome is decided. If the baby is delivered by the normal delivery, the gut microbiome is different. And if the baby is delivered by C-section, the gut microbiome comes out to be different. So when we talk of dysbiosis means that, there is a disbalance amongst all the components of the ecology of the gut. So how does it get affected? So it mainly, one thing is, as I shared with you, the method of birth of the baby. That is one thing. Then cigarette smoking, alcohol consumption of red meat, lack of or deprivation of sleep, too much of stress, then intake of too many antibiotics. We all now understand that antibiotics are not good for us. Too much of antibiotics is not good for us, but then this is one of the reasons because of which we say that antibiotics are not good for us. Obesity, there is a very two-way kind of phenomena. An obese person leads to dysbiosis of the gut, and then a vicious cycle starts, and dysbiosis leads to further obesity, and the cycle goes on. So obesity is another thing which leads to loss of equilibrium or disturbance in the equilibrium of the gut microbiota. Then people who have undergone radiation therapy, or the people who are, by profession are exposed to radiation. With age also, the dysbiosis sets in. So they say that after the age of 50-55, one should start taking care of one's gut very strongly, because this is the age when dysbiosis starts happening naturally. So you need to look at your diet. You need to be more careful about your diet, and of course the diet of your patients once they are, they've crossed the age of 50. Then helminthic infection, viral infection, all kind of infections in the gut, they also lead to dysbiosis. And then finally the inflammation. Inflammation we all know is bad for everything. Inflammation actually has been found out to be the major cause for all the kinds of cancers. So inflammation in the gut, or even in the the parts, the organs which are touching the gut, like uterus and liver and so on. So any kind of inflammation therein also leads to a dysbiosis. So this is basically the spectrum of the factors which are affecting our gut equilibrium in a negative way. So what happens when dysbiosis occurs is the potentially pathogenic bacteria, their number increases. Good bacteria, their number decreases. And because of, the intake of certain foods, wherein we have some antimicrobial agents or microbicidals, or the pesticides have been used. So they kill the good bacteria also. Since they have been able to kill the pests and the bacteria and the fungi on the plants, of course they will be having some capacity to kill all kinds of bacteria. So they kill our good bacteria to the extent that when somebody takes food perpetually for a long time which contains such kind of pesticides, there are certain bacteria or certain fungi, certain strains of fungi that become obsolete completely. So you miss those good bacteria. And then of course, both the alpha diversity and the beta diversity of the microbiome, of the microorganisms, that goes down. And we all know that both alpha diversity and beta diversity are essential for a good kind of ecology in the gut. So once we lose or once we compromise on the gut diversity, it again leads to certain disease conditions or certain pathological conditions. So intestinal conditions wherein dysbiosis is known to play a very strong role. These include the recurrent Clostridium difficile infections, the ulcerative colitis, Crohn's disease, then inflammatory bowel syndrome, diarrhea, constipation, and of course, the colorectal cancer. All these 1, 2, 3, 4, 5, 6 things eventually, if they are chronic in nature, will eventually lead to the formation of colorectal cancers. So all these intestinal conditions are very strongly related to dysbiosis. Then, when we talk of the extra-intestinal conditions, now situation is that we say there is a gut-brain axis, we say there is a gut-skin axis, we say there is a gut-lung axis, or gut-pulmonary axis. So virtually every condition, every negative condition is now somewhere being associated to the gut microbiota. So the diseases wherein the strong association between dysbiosis and a disease and a pathological condition are very strongly reported, include multiple sclerosis, Parkinsonism, Alzheimer. So all these three, would be included, would be attributed to the gut-brain axis. The onset of Parkinsonism and Alzheimer, these are known to be postponed in the inherited kind of situation also, if the dysbiosis can be prevented. Then we have PCOS, polycystic ovarian syndrome, a metabolic disease. We have Parkinsonism, again related to our brain. Then insomnia, where there is a lack of sleep, chronic lack of sleep is there, that is also attributed to a disturbance in the gut ecology. All kinds of arthritis and gout, both kinds of, the synovial problems are also somewhere attributed to the dysbiosis, and it has been reported now, there are some clinical trials also that indicate that if the dysbiosis gets rectified, if that is treated, arthritis and gout also improve. The patient improves. And similarly, when we talk of PCOS, diabetes and obesity, which are related part of metabolic syndrome, they also are very strongly attributed to the gut dysbiosis. Then we come to certain psychological diseases like depression. Now, in fact, I have not included it here. They say that the susceptibility to addiction. Many a times we come to know that there is a family, wherein there are two children. Both the children are exposed to similar kind of environments. But one child, falls prey to addiction, the other doesn't. So it is now being said that the liability to any kind of addiction, whether it is cigarette or alcohol or drug abuse, is also somewhere regulated by the gut dysbiosis. So the better the gut ecology, the less are the chances of any kind of addiction liability. And then we have, as I shared with you, the gut-lung connection. So COPD is also attributed to the dysbiosis of the gut. So moving on, we'll talk of various options. So first we'll talk about probiotics, which are basically the good bacteria. All of you might have heard of probiotics. They are the latest hype. So many people would take probiotics in the form of, small shots, 60 ml or 30 ml shots in milk or curd, or even tablets and capsules are now available. Many drinks are available, many powders, sachets are available. Now even ice creams are available, which are claimed to be containing probiotics. So probiotics are the live bacteria which are supposed to be good for your gut. Then we have another category which is prebiotics. So prebiotics are basically nothing, they are the food for probiotics. So we are giving probiotics also, and we are giving them food to thrive upon. So we are basically strengthening the good bacteria of the gut. Then there is a combination of the two. So you are giving good bacteria and you are providing food also to them simultaneously, so that they can survive and then they can thrive also. Now prebiotics, since it is a food, it is basically polysaccharides which are not digested in the upper part of the gut. So the stomach will not be able to digest it. Upper part of the intestine would also not be able to digest it. So once it reaches the colon, the polysaccharides get digested by the good bacteria themselves. So these are non-living kind of things. Probiotics are living because they are the bacteria. So either we will be administering spores or we will be administering live bacteria. So if it is a milk kind of drink or curd, then it would be live bacteria. If this is a capsule or a tablet or a sachet, it would probably be spores of the good bacteria. And prebiotics are not live. They are not living. They are basically the polysaccharides which are broken down by the gut microbiota. Then when we combine the two, we get symbiotics. And then we have a fourth category, which is metabiotics. Now, metabiotics, as the name suggests, you see, it is a combination of two words, meta and biotics. So it is basically the metabolites of the good bacteria. So the metabolites of probiotics are known as metabiotics. And again, they are not living because they are chemicals. They are the metabolites basically. And then the last category is something which is very interesting, you know, the fecal matter or the poop from healthy persons can be transplanted to the patients, and it has been found to be very good. It has been found to be very good in certain intestinal and even in certain non-intestinal diseases. And you know, it is of course the fecal material contains certain live microbiota, so this also falls under the category of living microorganisms. So one by one we'll take up all the options, and it is my request to all the audience that if they have any questions, they can put it in the chat box, or they can ask me. If they want to ask now only, they can ask now, or if they want, they can ask me at the end also. So as I was sharing with you earlier, probiotics are basically living microorganisms. This includes currently, you know, in the market we have both bacteria as well as fungi. So bacteria, we have lactobacilli, which is the most popular species, and we also have amongst the fungi, we have the Saccharomyces, which is the most popular kind of probiotics in the fungal category. So probiotics are basically living microorganisms, which when they are administered in adequate amounts, so that is a very important phrase. If you administer them in very small concentration, you know, the advantage could not be harnessed because the concentrations would be very low. In fact, what they're going to do is they're going to displace the bad bacteria from the gut. So we need them in ample number so that, you know, they are enough in number to displace the pathogenic bacteria from the gut. So they have certain beneficial effects on the health of the host. So if you would see, there is a picture at the bottom of the slide. You can see that, you know, it is in case of the geriatric patients. Also, good probiotics are quite helpful. They are very supportive for the geriatric patients. For the patients who are suffering from inflammation, fever, again, probiotics have been you know, reported to be very effective. And when somebody is in good health, you know, they are able to sustain the good health also. So healthy people should start taking probiotics while they are healthy only, so that, you know, there is a preventive role also. They are able to exert a preventive role also. So they say that people who take care of their guts well, you know, the onset of geriatric problems like Parkinsonism, Alzheimer is postponed by as long as a decade amongst the people who start taking care of their guts in the early 20s or early 30s. And another thing is, which is now very well documented, is that the more processed food you eat, the less is the prebiotic and probiotic content. So the more are the chances of developing all these psychological and neurological. So psychoneurological pathologies, it increases much higher if the processed food is eaten. So the next generation needs to be very careful about their food habits. So moving on. Now, how do the probiotics, they affect the health of the gut? So most important thing is, you know, there is going to be a limited number of microorganisms inside the gut, because there is a limited space, there is a limited food available, right? So they are going to compete with the bad bacteria for space also. You know, the bacteria or the fungi, they generally adhere to the gut wall. So there would be a competition for the space also, and there would be a competition for the food also. So when this kind of competition is there, you know, if the number of the good bacteria is more, obviously they will, you know, reduce the number of the bad bacteria or the pathogenic bacteria. Then we all know, you know, sugars are not good for us. So the probiotics are very efficient at reducing the sugars or fermenting the sugars further to smaller molecules. Now, when we talk of smaller molecules, we have short chain fatty acids. So short chain fatty acids are the latest mantra for good health. Particularly, you know, the butyric acid or butyrate is supposed to be having very strong anti-diabetic activity, anti-cancer activity, antioxidant activity, and so on. So these good microbiota or probiotics are able to further ferment the sugars to smaller chain fatty acids, which are very good for health. They are very strong anti-inflammatory substances. Then, you know, they also lead to good bacteria also lead to production of vitamins. The two categories of vitamins which are very strongly, I would say, produced by the probiotics include vitamin K and vitamin B. So vitamin B1, 2, 4, 6, 12, all are dependent upon, or all are synthesized by the probiotics. Then they also produce bacteriocins. Now, as the name suggests, so bacteriocins are going to kill the bad bacteria. So they are antimicrobial substances which act specifically on those bacteria which are not the probiotics. Then they, as I shared with you, so they will compete with the pathogenic bacteria for a site on the gut wall also. All of you might be aware that the worst condition a patient enters eventually, unfortunately, before the final go or before death is the sepsis condition, specifically in case of infections, particularly, you know, infections like Clostridium infections, which are very, very fulminant kind of infections. So the probiotics are able to increase the integrity of the gut barrier, so that, you know, the all the pathogens or even the poisonous substances are not able to cross the gut barrier. So once the entry of the pathogens or the entry of the bad substances, I would say, the toxins, they are not able to cross the gut barrier. Obviously, you know, the infection would be less, the side effects would be less, the toxic effects would be less, and pathogenicity, or I would say mortality and morbidity, both will be reduced. So then, as I shared with you, since they produce butyrate, so they reduce the inflammation also, and they have a very strong effect on the innate immunity, the natural immunity of the host. So I would also like to share here that during the pandemic times, when you know, almost 50% or 40% of the entire population across the globe was afflicted by the infection, at that time also COVID was found to be less prevalent in the patients who were prevalent or less morbid in the patients who were on probiotics and who were having good natural food before and during the COVID infections. So that proves that the innate immunity or the natural immunity of a person is also enhanced by the use of or intake of probiotics. So these are some of the, you can see some of the mechanisms by which the probiotics act. So they compete for the nutrients, they compete for the space, they improve the barrier function, they stimulate the immune system, they lead to bioconversion, you know, producing the short-chain fatty acids, they produce vitamins and growth substances, they reduce the inflammation, and of course, you know, by bacteriocins, they kill the pathogenic bacteria also. So you can see how happy the microorganisms of the gut are when they are getting some good probiotics. So B and K vitamins are being synthesized, right? It is cleaning also. The motility of the gut is increased. So once the motility of the gut is increased, you see the problems like constipation and diarrhea are also taken care of. And then the gut gets cleaned up. All the substances which have been there stagnant for a long time are cleaned up by the probiotics. So as I shared with you earlier also, these are the various conditions wherein probiotics have been proved to be very effective by multi-centric clinical trials. So we have intestinal infections, antibiotic-associated diarrhea, as I was sharing earlier, colorectal cancer, helicobacteriosis or the infection by helicobacters, IBS, constipation, and lactose intolerance also. So that is also a very interesting thing. The patients or the babies or the children who have lactose intolerance, if they are given probiotics, you know, their intolerance to lactose decreases. Then when we talk of their uses beyond the gut, they are good in allergies. The reason being, you know, the immune system is fortified, obesity, weight management, osteoporosis, because you see certain vitamins are increased in synthesis, certain vitamins are, or certain substances are metabolized more quickly. In diabetes, now we have a number of clinical trials which are proving that they are very good for all kinds of metabolic diseases. Alzheimer, even in acne, you know, acne we used to think is related to the skin, but somewhere it is also related to the gut. I would say I don't know about the other parts of the globe, but in India, whenever a person has a bout of acne, the first thing which is advised by everyone is stop taking oily food or stop taking processed food. So people the children, specifically the teenagers, you know, who are on pizzas and burgers, they stop taking the processed food when they have an outbreak of acne. So once you shift to the natural foods, acne subsides. So that is attributed to the good bacteria which are there because of prebiotic intake. Asthma and respiratory infections also, and you know, many problems of vaginal pathologies are also taken care of by the probiotics. So then we come to the various strains. Most of the probiotics are administered in the form of, you know, milk powders or milk shots also, yogurts, curds, cheese, and ice creams also. So most of the, you know, the common bacterial probiotics, as I shared earlier, also are bifidobacteria and lactobacilli. While the, if you talk of the fungal probiotics, Saccharomyces is at the top currently. In the market, you will find lactobacilli, you will find bifidobacteria, and you will find Saccharomyces. So these three are the most popular kind of strains. But there is too much of a hype, and we'll be coming to the, you know, the negative aspects or the limitations of the probiotics also. So only in India, you know, about $523 million business was there by the probiotics in last 1 year. So now coming to the negative aspects or coming to the limitations of probiotics, you know, when we take strains which are basically not indigenous to your geographical area, you see, the gut of a person who's living in Asia would be different from the gut of a person who's living in Europe, from a person who's living in US, and maybe, you know, from a person who's living in Africa. So our ecologies of our guts would be different. So giving the same kind of probiotics to all the people without any kind of personalized changes would not be good, because many of the bacteria, once you give them, you know, they will live their lifetime, but after that they are not able to colonize inside the intestine if they are not indigenous to that population. So they are not able to survive. They would be able to survive their own life cycle, but they would not be able to reproduce or give rise to more such bacteria. So their life goes only till their own life cycle. That's it. So they are resistant to the gut atmosphere or the gut ecology of a population which is different from the indigenous population. Then generally, as I shared with you, lactobacilli, bifidobacteria, and Saccharomyces. When we generally have a combination of 2 or less than 2, or at times even 3, it becomes very difficult for the microorganisms to be stable in the new kind of ecology. So we need a larger number of species to make sure that they stay on for a long time. So as you can see, I've written there are minimum 18 strains should be there for a long time effect of the probiotic. So these are all the limitations of the probiotic therapy. So again, the same thing, there is a strong competition. If they are giving competition to the pathogenic bacteria, you see the pathogenic bacteria is also going to give them some competition. So they face tough competition from the own gut microbes of the host. And generally, when we characterize the gut microbiome, we generally don't like to, go invasive. We would not like to enter into the gut. What is generally done, 90% of the cases is, we take the fecal material and analyze. Now that gives a wrong indication because the microbes which are present in the feces are very different from the microbes which are colonizing the colon or even the upper part of the intestine. So stool samples are not very good indicators for the gut bacteria. Then another thing is, especially in case of capsules and tablets, they are being sold as spores. They are not live. So many of the spores are not able to give rise to vegetative microorganisms. So they just be there and they are passed out with the fecal matter. So looking at all these limitations of the probiotics, the scientists thought, why not, give prebiotics, because some good bacteria are already there. So you can see in this inset, these are the green things are the probiotics or the bacteria and the fungi, while the red things are the prebiotics. So they are the food for the very good bacteria. So then there was a trend for prebiotics. Prebiotics are basically food items which are not digested in the upper part of the GIT and are not therefore absorbed by the host. They have, of course, the beneficial effects. That is why we are administering them, and they stimulate the good bacteria selectively. That is the best part about prebiotics. There are certain substances which are eaten preferentially, selectively by the good bacteria. Therefore, they promote the growth of good bacteria and inhibit the growth of the bad bacteria. So they give certain good health advantages. So we'll just compare the two. If you can see, these are the probiotics which are live bacteria. These are the prebiotics which are basically non-absorbable polysaccharides or oligosaccharides. So they are put into the intestinal microbiota through, they will act on the intestinal microbiota which is there in stomach, small intestine as well as in colon. So they improve the barrier function, they suppress the pathogenic bacteria, and they enhance the immune function of the host, natural immune function of the host also. So this I think we have more or less already discussed, yes. So generally, when we talk of prebiotics, these are a few very popular examples. Like we have oligofructoses, we have inulin, galacto-oligosaccharides, lactulose is there, pectin. When we peel an orange, we throw away the white kind of threads which are covering the orange. So that contains a large amount of pectin, which is actually very good for us. So peels are a very good source, peels of anything, most of the fruits and vegetables are very good sources of prebiotics. So rather than, throwing them away, we should try to include them in the diet. Cellulose and apple polysaccharide and mushroom poly. I forgot to mention that. Mushroom polysaccharides and apple polysaccharides are also very, very good prebiotics. So these are the differences. You can see prebiotics are non-living and probiotics are living bacteria. So they are, since they are living, so they are very fragile. They are affected by the heat. While since prebiotics are non-living, they are very resilient. They can withstand anything. And they nourish the bacteria, while these are the bacteria themselves. So then another idea came when prebiotics alone were not able to fulfill the purpose of giving very good health to the hosts. So scientists thought, why not combine both of them? Give probiotics and give prebiotics along to make them symbiotics so that, they can thrive for a longer time. Now the question arises, you see, the major issue was all the probiotics are not going to like all the prebiotics. We also have very selective choices as far as our food is concerned. Some of us like to have, spicy food. Some of us like to have sweet. And similarly, the bacteria and the fungi living in the gut also have their own choices. So every prebiotic would not be very good for every probiotic. So we have to reach a combination wherein, you know, they can work in synergy. So then when they do work in synergy, then only we are able to harness the maximum advantage out of them. And the combination of the two is very aptly known as symbiotics. So we have worked in our labs with probiotics and symbiotics. Just to you know, share a few publications. We have done up to preclinical testing. 2 of our products are currently being taken up by some industries, the pharma industries, for you know, taking them ahead. So you can see we have worked on probiotics along with prebiotics for colon targeted delivery for basically IBD, that is inflammatory bowel disease. You can see for ulcerative colitis also. So we started our work somewhere in 2013, and in 2015 we started publication of all the preclinical works. So then we have, again, you see sulfasalazine is very good in ulcerative colitis. So we have worked on 2 of the drugs and we found very good results for both when they were combined with the probiotics. Then again, we then used, earlier we were using powders and granules. Then we shifted to tablets also because the industry demanded that, you know, it is very difficult to administer powders or granules. So we shifted to mini tablets also. Then we found out that it is very good for wound healing also. This was also done on rats. The probiotics and prebiotics were found to, you can see collagen and chitosan. So chitosan is a very good prebiotic. So when you give a combination of the two, it gives an impetus to the wound healing also. There is quicker and there is more substantial kind of wound healing. Then this is a book chapter on metabiotics. We'll be coming to that also. Then we have worked on the diabetic foot ulcer also. So one was plain wounds, second was wounds or the you know, the injuries that are sustained because of diabetes. All of you might be aware that, you know, healing of wounds is much delayed in case of diabetic patients. So for diabetic foot ulcers also, when we combined the prebiotics and probiotics, we found that it gives a much quicker healing. Bezolytic activity was found again in the rodent model. Then this was polycystic ovarian syndrome was, it has been worked upon by one of our masters and one of our PhD scholars, and we found a very good role of symbiotics on PCOS. Then in myasthenia gravis also it proved to be very effective. So you can see there are so many intestinal as well as non-intestinal, particularly metabolic syndrome kind of diseases wherein the combination has proven to be very, very useful. This is the work only from my lab. So when we talk of the overall clinical trials going on, you name any disease and, you know, you find the role of gut microbiota in that. So this is the patent which has been granted to us for a probiotic based delivery system. And this is my scholar, one of my scholars who presented her work, which was very highly appreciated in case of diabetes. So probiotics and prebiotics combination in treatment of diabetes. So she presented her work in US in APS meeting. And there were 2 Nobel laureates also who appreciated her work quite a lot. Then we come to the 4th category. Again, you see some living, some non-living. So the scientists thought, why not look at the metabolites of the microorganisms? So they were given the name of metabiotics. Now, these are the substances which are produced by the probiotics while they are living or even after they are dead. So generally, when the the probiotics are killed, we call them postbiotics, but metabiotics would include both the metabolites as well as the you know, postbiotics. So advantage is, you know, at times the doctors are or even the patients are a little skeptical, you see, about taking live bacteria. So since these are non-living, so it becomes more convincing for a physician to, convince for the patients to be convinced for taking this. And then you see, once they are non-living, we know their composition. We can analyze them very nicely by HPLC or HPTLC. But for the living bacteria, it becomes at times very difficult to analyze them also quantitatively as well as qualitatively. So when we talk of metabiotics, these are the components. We have SCFAs, short chain fatty acids, polyunsaturated fatty acids. We have I have talked about all these three. So polysaccharides are also there. Some amino acids are also there. Plasmalogens are there, which are basically small parts of the cell membrane. Then vitamins, as we discussed, this is B as B complex as well as vitamin K and aptamers. These are there as metabiotics. So how do they act? They decrease the pH of the colon. Increased pH is very bad for us. It leads to development of cancer eventually. So the SCFs, they short chain fatty acids, they inhibit the pathogens. They improve the integrity of the epithelial cells. So barrier membrane is strengthened. They enhance the immune function. They have antioxidant activity, cancer selective cell lysis. So they are able to recognize the cancer cells and selectively kill them. They also capture the carcinogenic substances, which is attributed to plasmalogens. So these are a spectrum of activities of metabiotics. So I think now it is understood. I can skip this slide. I'm taking too long, probably. I should not, take more than the time allocated to me. So then we come to FMT. Now, FMT is a very interesting kind of, I would say, a non-pharmacological intervention. What is done is the fecal matter from the healthy persons is taken. It is, mixed, some water or some buffer is added to it, and it is mixed thoroughly and it is filtered. So the material that remains is basically containing the probiotics and the metabiotics and the postbiotics basically. So they are administered to a patient either orally or through the colonoscopy or through other routes also, wherein we can actually make a surgical lesion and give it to the patient. But it has been found to be, you can see right at the top, in case of recurrent Clostridium difficile infection, it has a success rate of more than 90%. In recurrent, not in the normal. In the normal one, it goes up to 98. So in the recurrent Clostridium difficile infection, it goes to more than 90%. Then you can see the success rate is IBS is also very good. Constipation is also very good. So, something which we could never think of, the fecal material or the poop is being used by the physicians or the doctors for treating many diseases which were considered to be untreatable. So how do we generally administer is we give by colonoscopy. We can give through the rectal route by enema, or we can give through the nose, reach the tube, make the tube reach the duodenum through the nose, or the jejunum, nasojejunal tubes. Oral capsules are also available in the market now. Or, we make a small cut in the skin and do the endoscopy through cecostomy. So cecum is given a cut, skin is given a cut, and then cecum is given a cut, and then it is put through the tube. Or we can give transendoscopy also. So these are the various routes through which it is given. Success of it depends upon the route of administration, whether it is fresh or it is frozen. So generally people have found that the fresh FMT gives better results. How much volume you have given. If more is required, you need to give more, or you need to give it for consecutive 3 days also. Then you need to repeat it on weekly basis also. This is what I'm saying when I say single or multiple. Then whether the donor is related to you, or it is non-related donor, or it is a super donor. Super donors are basically people who have very good bacteria in their gut. So they are known as super donors because their fecal matter can be donated to anyone across the globe. Then, patient compliance, which would depend upon convenience as well as cost effectiveness. So what happened initially, you know, the success rate was so good that people started doing it themselves. So then came the regulation that it cannot be done by anybody who is not a qualified physician. So these are the FMT preparations which are already available in the market. They are commercially available. So the doctors are purchasing them. They are frozen kind of things which can be given. So this is given by colonoscopy through the lower route. This is for nasoenteric or gastric tube. And then these are the capsules which are to be taken by the oral route. And then, you know, since the acceptance of FMT was not very good because of, you know, certain effect which is always related to fecal matter. So some patients or some doctors were not very receptive about the idea. So that was one very strong limitation. Then, you know, if the host is having the donor is having any kind of infection, that can be passed on to the recipient also. So there were chances of risks of infection transmission also. And then, you know, fecal matter of one person would vary from the fecal matter of the other. So standardization was becoming very difficult. So after that, the latest in the non-pharmacological therapy is the bacterial consortia. If you remember in the probiotic limitations, I discussed that you need to have at least, you know, 18 strains for any probiotic to be effective. So this is the job which is currently being done by the bacterial consortia. So as the name suggests, it is a group of bacteria, but they are very specifically identified. Their concentrations are measured and then they are administered to the patient. So these are a group of complex microbial communities containing something around 20 to 25 strains, and they offer therapeutic advantage which is equal to or at times found to be more than that of FMT also. And side effects are much less. They are more acceptable by both the physicians as well as the patient. So this is the non-pharmacological intervention, which is the most recent one, and on which, you know, a number of clinical trials are going on. So that's all from my side. I'll be happy to answer any questions if there are.
Dear Dr. Gulati, thank you very much for such a wonderful presentation and valuable knowledge that you give it to us. And yes, dear guest, if you have any question, you can write in the chat box. We can check from there, and then we are going to continue with the questions. There is a question here. Thank you very much, Professor. According to a recent publication, gut commensal bacteria of mice can translocate to the brain via the vagus nerve where fed a high-fat diet, or in mouse models of Alzheimer's and Parkinson's. What are your thoughts on these findings? There was a question related with that. Maybe you can check it in the chat box, Professor.
Yeah, I've seen the chat box also. So the observation of the scientists, they are very right. You know, once the gut gut membrane integrity is compromised, there are always the chances that, you know, the bacteria can translocate either to the nervous system or even to the vascular system. Now, vascular system is taken care of because of the blood-brain barrier. But when we talk of the nervous system, the nerves, you know, in the nerves, there are no barriers. So if it enters into the blood, probably the blood-brain barrier would be able to take care of the live bacteria or the commensal bacteria. But even the blood-brain barrier would not be able to take care of small molecules, small, I would say, toxins, if they are produced and if they manage to cross the gut barrier. So this would be very much possible that they can translocate to the brain and lead to any kind of infections inside the brain. In fact, I'll share a very interesting observation with you. Recently, there was a case received in one of the very good hospitals, multi-specialty hospital in India, in Punjab, wherein it was found that there was some translocation like this, and the patient started growing some hair inside the brain. So you see, it is very much possible. Whatever translocation you are saying, it is very much possible. So fat diet is basically reducing the gut integrity of the gut barrier, because of which translocation is taking place. I hope I have answered your question.
Thank you, Professor. Yes, thanks to you here. And I have some question already from the students that are in the class and watching you from there. But before that, there is a chat box, one more question here. Thank you for sharing this essential information with us, said. I'm looking for an answer to a question about our everyday lives. What role does lifestyle, including physical activity and stress management, play in the shaping of the gut microbiota and its potential for disease management?
I would say a very, very strong role. You know, there is a vicious cycle, or you can say there is a virtuous cycle, positively if we speak. So if you are having a good night's sleep, you are not stressing yourself, you are moving yourself, you are exercising well, and of course, you know, you have good thoughts, everything matters. So this kind of lifestyle, and of course, you know, you are not insulting your gut bacteria. If you are feeding very, yesterday I was reading somewhere, don't treat your gut like a gutter. Right? So don't put anything, any trash into your gut. So whenever you are eating something, just think whether you like it or your gut bacteria are going to like it. So it should be liked by both. So your lifestyle is having a very strong impact. As I shared with you, insomnia or lack of sleep leads to dysbiosis. Stress leads to dysbiosis. Eating habits leads to dysbiosis. Obesity, lack of exercise, all this leads to dysbiosis. So we must take care of each part of our body if we want to stay healthy, because everything is going to affect the gut, and the gut is going to affect everything.
Yes,
Any more
thank you.
questions?
I think that is the answer, and the professor already is satisfied with that one. And another question is that just came to me from the students. They said that what strategies and interventions have been effective in modulating the gut microbiota, maybe to improve metabolic health and prevent obesity and related diseases? Is a little bit different, but it's a question for that. Do you have any idea about this one?
When we talk of metabolic diseases, we mainly count diabetes. We count hypertension also in metabolic diseases. We count obesity. And of course, you know, then there are secondary implications of all these, including neuropathy, you see retinopathy, XYZ, everything. So when we talk of metabolic diseases, they are very, very strongly affected by the gut health. And the interventions that have been proven to be good for them in the clinical trials, in the multicentric clinical trials, are all three, rather I would say all four. So probiotics, prebiotics, symbiotics, and FMT. All four have been found to be quite useful in the metabolic disorders. Now the clinical trials are going on regarding the bacterial consortiums.
Thank you, Professor. And due to the time, I'm just one more question. What are the challenges and opportunities in translating research findings of gut bacteria and non-pharmacological treatments into clinical practice and public health recommendations? It's another one.
Yeah, there are two major issues related to bacteriotherapy, as we call this. All these interventions are known as bacteriotherapeutic interventions. The major two limitations is, number one is lack of standardization. So standardizing the live bacteria is a little difficult. It is not a little difficult, actually it is too difficult. So in all parts of the globe, we would not have an infrastructure or the facilities available for very clear-cut kind of standardization of the microbiome or the probiotics. Another very strong limitation which is being faced by these bacteriotherapeutic interventions is that, you know, the people are not very receptive. Specifically for FMT, many people have a reservation against, even administering certain religious connotations are also there. Certain people consider it impure or dirty or something like that. So receptivity of both the physicians as well as the patients is a very strong limitation in these kind of bacterial therapeutics. So I hope
thank you, Professor. Yes, thank you, Professor. And I just thanks to you a lot for replying. And today we are for the first session, we are completing now. And I would like to thank you so much for being with us, because I know that you are too much busy. You have an academic staff that you are deal with, but already you are a dean of the faculty, so it's not easy, I know. So the first our 3 speakers today was the 3 deans of their own faculties that deal with some administrative duties. So I would like to thank again you for being part of this symposium and sharing your knowledge with us. For now, we are just going to give a 1-hour lunch break. And after we are going to continue with Dr. Amber Sharif with the next speaker. So thank you again for all of you.
Thank you so much. And I would just like to share that if there are any questions afterwards, also if there are any afterthoughts, you can always share them, with me. You have my mail ID available with you. And if anybody wants to work on this, we can go for collaborative work also. We'll be very happy to host any one of your scientists here. And even if it is, through any kind of online meetings or anything, we will be very happy. My group would be very happy to collaborate. So thank you, Professor Mani. Thank you so much.
Thank you also for all of you, and also dear one of the staff, Navin, that already we were in the contact with you to share all of the information. So thank you again, and of course we will share your contact information with our scientists and our academic staff and our international office in the future. Of course, we will be honored to welcome you here in our campus, in our university, and make another conferences that maybe they will be face-to-face. So thank you again for all of you for being part of this symposium.
Thank you.
Thank you. So just I would like to give a brief information. Now we are on time and we have a 1-hour lunch break, because maybe the audience, they have need a break just for 1 hour. And then we are going to continue with the next speaker, who is Dr. Amber Sharif and Professor Dr. Lukman THALIB. So let's see you after 1 hour, and we will be here. We will continue from the same link, from the same Zoom link. Thank you for all of you, not only for the speaker, but also for the guests, the participants, the students that are in their own class watching us here. So thank you again, and see you after 1 hour. Dear guests, welcome again. We will continue with another speaker, Professor Dr. Amber Sharif. Dear Dr. Amber, do you hear my voice, just for information?
Yes, you are audible to me.
I think, yes, you are here. I make you a co-host in order to share your presentation. But before that, I would like to give a brief information about the Professor Sharif. When we check about Professor Dr. Sharif, who is one of our speakers today, we see that the professor finished the bachelor degree in the School of Pharmacy from the University of Lahore from Pakistan in 2011. After that, the professor continued in the pharmacology and toxicology and the University of Veterinary and Animal Science for master degree, and in the Pakistan again in 2021, the professor earned the PhD degree in this field. The professor is working now as an assistant professor at the School of Pharmacy since 2021 in the University of Management and Technology, and also is worked as a researcher for 6 months in the Nanomedicine Regenerative University of Strasbourg in France. When we check about the current administrative duties, we see that the Professor Amber is working as a leader in the community pharmacy services and pharmacy enthusiastic society since 2023 at the same university. And the research interest of the Professor Amber are the pharmacological evidence and the cardiovascular pharmacology. And of course, if I miss something, I would like from the professor to mention or to add here again. And I would like to thank again Dr. Sharif for being with us today here. Thank you for your valuable time and welcome to our symposium. So I'm stopping my sharing, so now you can share your presentation, and welcome again to our symposium.
Thank you so much. Good afternoon, everybody.
Your voice is not coming, Professor.
Let me check it. Am I audible now?
No. Just now? Do you hear me?
Yeah, you are audible.
Yes, now it's coming. Yes, everything is okay.
Okay. Okay, thank you so much, Professor Armani. Good afternoon, everybody. And thank you again for such a sweet introduction. First of all, I would like to express my gratitude for having me on board. And yes, I would like to congratulate you as well for organizing such an informative event. Okay, let me share my slides with you so that I can proceed. Okay, is it visible to you? I cannot hear you. Professor Armani, is it visible for you?
It's visible to us, but could you please do it at full screen?
Yeah. Okay.
Yes. Yes, thank you. The speech is yours. You can start.
Thank you again. Today I'll be discussing combating skin diseases using natural resources. When we talk about natural resources, the point which comes in our mind is why plants? Why not something else? Even when we are in research or when we try to formulate a new product and we want to work in the plants, then why plants? Let me answer that first. Because the history of natural product is as old as human civilization, and so is the indigenous knowledge, of course. So that indigenous knowledge is handed down to the people from their ancestors through verbal communication. I believe that is the most effective form of communication. And people have been living in close associations with the plants since time immemorial. So I can say this is reliable. It can be a reliable source for us. So the purpose of standardizing traditional remedies is obviously to ensure therapeutic efficacy of medicinal plant. And the value of ethical medicine in modern pharmacology lies in the development of the new drug. And this is very, even effective. I'll tell you in the coming slide. This study basically explored the fundamental knowledge on various dermatological problems which were solved using medicinal plant, and is aimed to provide a baseline for discovery of the new plant having activities against skin issues. While studying this, a total of 244 published articles were reviewed, and the focus was on the plant with potential traditional usage against various skin diseases. A master document was formulated enlisting medicinal plant for the treatment of several skin ailments. And that master list constituted the vernacular name of the medicinal plant along with the family name, card use, mode of preparation, and the skin condition against which that was used. Now, I'll tell you which point I just left, why the plant is important, why the study of the plant is important. After we published the study, a company from Pakistan contacted us and they wanted our data. We shared the data. We had several meetings. We formulated a new drug for them. We had several trials. Even some of the trials are still under progress. We did toxicity studies, and now they have their plant-based products in the market. Now they're marketing the product, and that was, I'm very proud to say that was based on the data we managed to publish. How the data was collected, the whole data was categorized into 26 categories on the basis of skin condition, 28 categories on the basis of families the plant belonged to, 7 categories on the basis of mode of preparation of the plants, 30 categories on the basis of part use, and 9 categories on the basis of habit the plant belonged to. Also, conservation status was evaluated, which is very important. Because, you know, when we are to make the medicine from the plant, the first thing which we have to keep in mind is the conservation status. Because, you know, when we have to deal with the plant, we often have to use the root of the plant or at times the whole plant. So when we uproot the plant, we are keeping that in the endangered list. So the conservation status is also, always very important, and that was evaluated using IUCN Red List version 3.1. Also, economical importance of the plant was estimated by consulting scientific data. Well, that was not as simple and as easy as it seems and as it sounds. We encountered several problems, several taxonomical problems. There was a lot of missing data. There was a lot of errors regarding family name, botanical name. There were a lot of problems. So all the problems were verified. The names were rectified using several search engines, Google, Tropicos, plant list. And after verification, after rectification, the whole process started. And the study revealed ethnomedicinal use of 545 plant species that belong to 118 families and 355 genera. So see, that is a huge number, 545 plants. So out of those 545 plants, we had to, you know, choose a top one. So it took a lot of effort to deal with those 545 plants, to verify every small aspect of that. And the 10 plants were finally selected based on different, we categorized the data, and then we picked the plants which were on the top of each category, like, for example, life form. We had to make sure that the plant is available around the year with the minimum variation. So based on certain parameters, 10 plant species belonging to different genera and family, which was most commonly used against several skill ailment, was then selected and studied in detail. You can see the result in terms of percentage of commonly used family. Ejaz was a family which was used widely for the treatment. Ejaz, Fabaceae, and Rosacea. So these 3 families were then picked up by us and presented to the industry so that we may proceed with some, manufacturing perspective. So the point is, why Ejaz hold the top position in the group? Because Ejaz hold the top position among the families used in ethnomedicine, which indicate the presence of effective bioactive ingredient in the member of the family. Also, Ejaz family is one with the most diverse members. It is found almost in every habitat, in every region except Antarctica. So that is one of the reasons that it holds the top position, and yet another reason we chose a family. And also because the family includes a large number of species. Then medicine in foreign genera, along with the number of species used effectively against skin ailment, was evaluated, and it was seen Euphorbia and Artemisia, they hold the top position. And on the basis of this, Artemisia was chosen that we can proceed with this genera. Then the point which was of concern, that was which skin condition can we target. For that, we had to, plot a table, and we had to again dig up the literature, and it was seen that wound healing was a condition that was on the top for the traditional healer to deal with. We all get wound every other day. So this is a condition we all acquire, even if that is a minor wound or if that is a bigger one. So in either case, the traditional medicine provides effective cure or effective treatment. Other than that, boils, pimples, eczema, ulcer, burn, infection and inflammation, ringworm, scabies, leprosy, abscess, you name it, and traditional medicine is there to treat that. So we have a lot of skin conditions which are effectively being treated with traditional medicine. Then the important aspect was the life form. So growing habit, when we were digging out the life form, again, we were so disappointed because the problem was a missing data. 42.2% of the plants were of unknown origin. The data was not available. So you see that is a huge number, 42.23. If we ignore that, the other life forms which was documented in the literature, that was tree, shrub, herb, creeper, climber, even grasses are being used, even sedges are being used. So the point or the important thing is why this data was collected. Because the life form or is important in terms of availability around the year. We cannot have all the plant life form available around the year. So we had to be very, careful about the choice. And other thing is there should be a minimal seasonal variation in the phytoconstituent. Then there was another important parameter, plant part, which was being used. The leaf were the most commonly used plant part in ethnomedicine, and this is due to the ease of processing them into paste and have less conservational issue than the collection of fruit, bark, stem, or the whole plant. And also because leaves does not affect the life cycle of the plant. Moreover, life form of the plant is not affected by collection of the leaves, and also due to the reason that leaves contain photosynthate, which may have some additional medicinal value. But when you talk about roots or the whole plant, no doubt that was also frequently used due to bioactive component, due to other phytoconstituents which they have. However, the excessive use of either whole plant or the roots, that can be detrimental for the survival. So we discourage the use of either whole plant or the roots. Also, we did the mode of preparation, and again we faced a lot of issues in terms of missing information regarding mode of preparation. Literature revealed that plant can be used in different ethno-formulation depending upon the sort of skin diseases we have to treat, and the type and part of the plant selected to treat the disease. The ethnometic formulation used for skin condition, it may include powder, paste, plant juices, ointment, poultice, extract various, it can be decoction or infusion or even other form of extracts. Okay, Medicinal plants are also used in combination with other medicines, with other vegetable oils, and with other nutrients. And this point was also the point of concern while formulating a medicine. And the oil, which is also mentioned here, apricot oil, this was again chosen by us, and now this is marketed because this is a very good carrier. People rely on synthetic interaction of the plants and supportive components like oil and milk to treat skin diseases. These supplement ingredients may be used to enhance the effect of herbal preparation or can simply be used to make the preparation palatable. Also, on the other hand, they improve healing condition. And the most important point is endangered species. Using the bark like root, rhizome, and bud could be a severe threat to the reproduction of the medicinal plant, of the herb, of that area. Unsustainability of harvesting of herbaceous root is well recognized by conservationists and term such medicinal plant as highly threatened. And we, as an ethnopharmacologist, we discourage the use of endangered species, and also we discourage the use of the plant which are in bulk, to uproot that, to use the whole plant or to use the roots. So there are some pictures of the marketed products on the basis of this research. Artinipar is one of the oil which is used against several skin issues, and this is a blend of juniper and artemisia. Like I just mentioned, artemisia is the top rank genera which is used against several skin conditions. They also have facial serum, which is a blend of sea buckthorn and cedar oil. There is anti-aging serum, and there are other, as you can see, there are also other serums and other oils which are used. Now they are, from the traditional knowledge, they have come into the market. And the point to present this here is that we can make use of the natural products very effectively. And being a pharmacist and being a member of ethnopharmacy community, I am in strong favor of using natural resources as a they don't have as much side effects as synthetic ones have. I'm not saying they shouldn't be used, but I'm more in the favor of natural products because of having less side effects. So that is all from my side. Thank you very much.
Thank you very much, Dr. Amber, for your presentation and giving information. Now I would like to ask that is there any question, and I'm waiting for some question from the students that are in place in their own class. So I just checking my phone for their questions. There is one question which is related with what clinical trials and research studies have assessed the safety and efficacy of natural research-based treatments for various skin disorders? I mean, what are their outcomes? They are asking us something like that.
Sorry, can you repeat?
Yes. What clinical trials and research studies have assessed the safety and efficacy of natural resource-based treatments for various skin disorders? So do you have any idea about the clinical trials in these aspects?
We are right now we are in the phase of preclinical trial, and inshallah within a month's time we will be done with that. We have conducted preclinical in the terms of acute and subchronic. Now within 2 months, inshallah, we'll be done with the chronic toxicity, and then we'll go into mutagenicity, because at times you have to use plant for a long period of time, and that may that can impose a mutagenic potential, or that can be, that can have a carcinogenic potential. So we might go into carcinogenicity, mutagenicity. So yes, all those preclinical trials would be first completed before getting into clinical trials. And they're, they're actually very safe, as the literature says, but for the, to prove it ourselves, we have to do that. And I myself am running that project for toxicity, and after chronic toxicity, we'll go into mutagenicity and carcinogenicity, inshallah.
Thank you, Professor. And there is another question. What are the challenges and opportunities in standardizing the production and formulation of natural resource-based skincare products for medical use?
Yes. When we are to formulate a skin care product, we have to be, very much conscious about the ratio of it. I'll give you example of my experience. It took us like almost 18 months to standardize a product. We had to make different ratios. We have to, keep on testing it on different animals to see the effect and the effect along with the safety. So when we talk about the plant and the standardization of it, we have to be very much we have to make sure that we are giving appropriate ratio of the plant, and the extraction technique should be according to the plant. So we have to count several several parameters for that.
Thank you again. And one more question, the last one. What are the economic implications of harnessing natural resources for skincare, and how can access to these treatments be ensured for underserved populations?
You see, the data which I presented, that was not only for Pakistan. If we deal with the plants, then obviously the economic status of the country would be raised, because we are using the natural resources of that indigenous region. When we use the resource of that particular indigenous region, it would obviously uplift the economy of the country. And we are on the way to use the natural resources rather than, importing it out. And yes, using natural resources does uplift the economy of the country.
Thank you, Professor, again. And because we will continue with the next speaker, I think these questions are enough. And I would like to thank again Dr. Amber for being with us today, for sharing your knowledge with us and with our students that are here and in their own class now. Thank you again for being here with us. So now we will continue with our next speaker.
Thank you.
Thank you. Our next speaker will be Professor Dr. Lukman THALIB. And before starting, I would like to introduce Professor. And the Professor is going to talk today about understanding the best evidence in healthcare and public health policies, and the Professor will mention about this topic in details. Before starting, I have to mention that have a very excellent career, I can say, the Professor Lukman, who has finished his bachelor degree in 1985 in the University of PEREZA, Sri Lanka, in biometry department, and then continue his studies in the University of Reading Applied Statistics, then master degree in biometry biostatistics, again at the same university, and the professor completed his PhD in biostatistics in 1993, University of Birmingham in UK. After completing the PhD studies, Professor continued for the postgraduate studies in the graduate certificate in higher education in the Griffith University, Australia, and postgraduate certificate in medical education in Dundee University. Besides education, I will mention some information about the academic career of Professor, where he started as a lecturer for 3 years work as a lecturer in the Biostatistics and Epidemiology department in the Griffith University, and then continue as an associate professor in the Faculty of Medicine for 5 years, and then as a professor again for 5 years in Department of Biostatistics. Since 2020, Professor Lukman THALIB is working not only in the Istanbul Aydin University, but also in the Griffith University in Australia, and the professor will be here from there. And the research expertise of a professor especially is in the clinical research studies, where he does research in medical data analysis, systematic reviews, meta-analysis, and evidence-based medicine. And of course, Professor has a high research productivity, I can say, because you can see Professor THALIB has over 10,000 citations, and where H index is 59. So I will let the stage to the Professor Lukman. He is going to continue with his detailed presentation and will be with us today from Australia. So I would like to thank you for your valuable time and welcome you in our symposium, Professor THALIB. It's your time, Professor, and I make you a co-host. You can share your presentation, and welcome again.
Çok teşekkür ederim Dr. Arta.
Biz teşekkür ederiz. Thank you.
Hoş geldiniz. Thank you very much, and that's the only Turkish I know. Anyway, is that the presentation is clear?
Yes, Professor, it's clear. We can see that. Could you please just make it a full screen?
Yeah. Is that better now?
Yes, it's better now.
All right. So slight changes to my title, maybe more suitable for the conference. I'm just going to focus on evidence synthesis for health policy and focus a little bit on meta-analysis. Then I realized there are a variety of audience you have. Students are also there. So I'm going to be basing my presentation to a reasonably, ordinary level. So if people who find it, repeating what they already know, my apologies, because I just, Okay, so assuming that everything going well, I'm going to move on. So is the voice and the pictures, everything okay? I mean, the presentations, Dr. Arta?
Everything is okay, Professor.
All right, because I'm not using the headphone. I thought I'll use my computer.
No, everything is okay. It's very clear.
All right, let's talk about evidence-based decisions. So health policy, everybody would agree, it should be based on robust evidence. I mean, the best and the valid and the most up-to-date evidence. Any health policy decision, doesn't matter whatever the areas that you are working on. And in terms of making such decision, you need to make sure that you have the highest level of competency in identifying and synthesizing and finding and applying this evidence. So it's about best evidence for health policy. Now, particularly this is important because we got both the quantity of the information and the quality of the information are just mounting. Any area you take it, it doesn't matter you wanted to, tobacco control, cancer screening, or whatever the area that you're working on, the enormous amount of explosive increase in the information is always a challenge when you try to make evidence-based health policy. So what do we do about that? So that's where the evidence synthesis comes in. Evidence synthesis thing about accumulating and bringing all the evidence that are out there into some kind of synthesis and get the summary and get the best out of it and the most valid that could be used in the healthcare decision making. So that's the whole idea. Now, when you talk about best evidence and then you're synthesizing or accumulating or bringing all kind of evidence comes from a variety of resources, contradictory, some of them on the same topic, same query. How do you go about? And there are sort of steps. Number of people will put different levels of steps. Some of the simpler way of looking at it is that you got a health problem, health policy problem. Okay, should we screen or not to screen, for example? How do we policy related to stopping tobacco, policy related to emerging diseases? That's it's a huge issues coming up. COVID or whatever it is, and then you have to formulate your problem. Then you look for the best evidence out there, and that means you have to search the literature. Something that we'll touch upon, because that's a very critical, because if you search it like in olden days, not comprehensive, and you only find you miss some major papers or major publication, you're not going to get the best evidence synthesis process. Then once you find out all the relevant publications, papers, or whatever the resources, and then you need to kind of look at them much more detail. Are they eligible? Are they talking about this? Sometimes you may be interested in, say, tobacco control, but then it is a tobacco paper, but then you're finding it, the outcome that they're measuring is totally different to what you're interested in. If you're interested in mortality or survival, and they're not dealing with that, they're talking about quality of life, then you will say that's not an eligible study for this particular policy decision that you're interested in. So once you sort of glean out from all these, literature, usually is a huge number when you search the literature, and then it becomes less when you only find the studies that are eligible. This is where you might be working on a framework called PICO, for example. You know what population you are interested in, what kind of intervention or exposure, and then what kind of control or and then what kind of outcome that you're interested in. What population, what outcome is very important. And then once you, based on those pre-planned questions, you will be screening for them. And then once you identify all those, 10, 100,000, sometimes we have, one of our SSI, surgical site infection among surgery, I don't know how many papers we are dealing with, hundreds came out potentially eligible. Then we had to extract data from those papers. Then we synthesize them. And here the data analysis and synthesis, various different methods exist. One of the options is, if there are quantitative, I'll talk about it more, is a meta-analysis. That's where I'm going to focus more on the step 5. How do you analyze this data come from different papers? So it's no longer a narrative review or expert review. You're actually analyzing the data extracted from this paper. That's where meta-analysis, that's where I'm going to focus more. Then, of course, you report and dissemination, and then you make decisions, and then you update or reanalyze, and new papers come out on that area. Okay. So something that I like to start my presentation on, this particular paper that got published in Science in 1994, not too long ago in a sense, of a scientific, modern scientific time frame. And a man who wrote an article in Science saying that, can meta-analysis make policy? Can the meta-analysis make health policy? Yes, it's a good question. And a very interesting paper. Anybody wanted to have a look at it, I would strongly recommend. Very small, it's not a big paper, it's only, this is the paper. It's only, a couple of pages, and very interesting. It says, can the meta-analysis help you make health policy? So one of the interesting part of this paper is this table. As you can see, the colorful table here, I'm just making it clear. I don't know whether it's too small for you, definitely for my eyes. Let me put my glasses on. Yeah, so he's trying to make a point here, saying that he just got number of issues that people were interested on. Psychotherapy, does it work? Delinquency prevention, school funding, does it help? Job training, is it any effectiveness? Is there anything happening because of the job training? Is it helpful? Reducing anxiety in surgical patients, is there any methods there? So what happened is he compared all those expert reviews out there, and then, for example, psychotherapy, he found that Eisneck published in 65, it's worthless. It was found to be not useful. But then when Eugene Glass in 1977, he's the one who actually started the meta-analysis out of his psychologist. So he did the meta-analysis of all the paper that where ISNEC throw them as a worthless, using a systematic analysis, not just expert review, he found a positive result. Is that psychotherapy does help. He himself, Eugene Glass himself was going through, he was doing his PhD and going through a lot of pressure and psychological issues. That's where he said, is psychotherapy helpful? So that's where everything started. So, and then similarly, school funding, surprisingly little direct impact on educational outcome. That was what published, but when they did the meta-analysis, they found important educational outcome due to the increased school funding or a change in school funding strategies, whatever. Job training was found to be not effective, but then was found to be effective with various conditions. Reducing anxiety in surgical patients, not conclusive, but when they did the meta-analysis, it became inexpensive 30 to 90 minute preparation session can reduce the length of anxiety, length of stay, and sharp impact on the cost. And so it's a reduction in some important outcome. So we're talking about meta-analysis is able to synthesize the evidence better in a way, and as different to the classical expert review. Now, what are we talking about expert review? Traditionally, the experts used to bring up all the papers published or whatever they want to choose, not all the papers, not systematically done. And they've come up with the conclusion, it works, it doesn't work. Do the screening, don't do the screening, and so on. The systematic review is one step ahead, where it would try to get all the papers published in that area. And then it's much more, I'm going to talk about the difference very soon, next table maybe. And then meta-analysis is not all the systematic reviews have meta-analysis, because they may not have a quantitative data, which I'm going to talk more about. This way I'm going to talk about. So meta-analysis is more systematically analyzing the data from all those publications and putting them together in some form. So which gives you a quantitative evidence for you to stand on. Systematic review could be more qualitative evidence. Okay. So very quickly, what's the difference between the narrative or expert review versus a systematic review? The question is very focused. In a traditional sense, they are very broad questions. These are working or not. In a systematic review, it will be very focused using a PICO. I don't know if people are familiar with that. The population, intervention, control, or exposure, and the outcome. That kind of structure is very clearly focused questions the systematic reviews ask. More importantly, the search. Narrative reviews just the way you want. The expert will just pick up the papers that they like. But it's not going to happen in systematic review. You need to do a very comprehensive search. We'll talk about search very soon. And at least Cochrane would say, Cochrane Collaboration is one of those people who are leading the systematic reviews. They would say minimum 3 major databases should be searched, and very comprehensive search strategy. And the selection, the expert review would be very biased. He may believe in antibiotic use or not use, and then they would pick up papers that they like. If they believe antibiotic is working for a ear infection, they'll pick up all those papers and say it works, or it doesn't work. But in systematic review, it's all criterion based. You cannot just do a selection bias. Everything had to be based on a priori selection strategy, the search strategy that you develop. How do you appraise? You say, oh, this paper is good, this paper is not very good. But here we have a very systematic way of looking at each paper and qualifying as a good paper or high quality paper or high risk, low risk, and so on. We'll talk about that a bit. In terms of how do you synthesize this evidence from all these papers, very qualitatively, they said, these papers are saying this or that. But in systematic review, particularly when you do meta-analysis, is a very quantitative, will show you some of the output that comes out of it. Inferences, sometimes evidence-based, not always. In a systematic review, it's most of the time it is evidence-based, and then it get updated like what Cochrane Group is doing. So go back to meta-analysis, which is a part of the systematic review. Not all the systematic review have meta-analysis, but a lot of them have when they have the data. So when you have a number of studies are looking at the same question related to health policy that you're interested, even clinical medicine, clinical research, any area. Now it's going into engineering, commerce, every area people are now looking at, not only the health. It's more focused on health. Started with the psychologist. answering a question, does psychotherapy work or not? Now it is done in every field you can think of. And so when you have multiple studies looking at the same question, same outcome, when you put them together, that's what basically meta-analysis means. So you have 4 studies, they're asking the same question, and you got data, they may not be saying the same thing, but they all are asking the same question. They measure the same outcome that you're interested in, say mortality and smoking. They all have that, maybe different countries, different level, different size. You combine them, and then that's what the meta-analysis does. Now, hierarchy of evidence that are used in the hospital, if you remember, people work in the hospital, level 1 evidence, level 1A, B, level 2, level 3, level 4, strong evidence, weak evidence, depends on which kind of health system you work in. Meta-analysis and systematic reviews generally produce the top level evidence. So you will see the pharmaceutical always come with the meta-analysis and try to convince you the new medicine is better, why don't you start prescribing to you? So when they have briefcases that they are walking around in the hospital, pharmaceuticals, sorry, I'm not offending, hopefully. I have my own views on that. But anyway, multi-million-dollar pharmaceuticals, they always have meta-analysis in their briefcase to convince you. But you have to be very careful. Some of the meta-analysis may be biased. Some of the meta-analysis may have thrown some of the important papers out to get the effect you want. We'll talk about that. Then the randomized control trials and cohort case controls are lower level of evidence compared to meta-analysis of systematic randomized control trial. So meta-analysis of randomized control trials probably the top, but meta-analysis of cohort and other studies are also equally good. So when you say you analyze the data from different studies, it's just an example. You have 1, 2, 3, 4, 5 studies looking at the same kind of outcome, same kind of intervention, same kind of population, and they all report an odd ratio. The first study reported 1.3, but it's not significant. As you can see, 1 is a null. So it's crossing 1. That means not significant, but 30% increase in whatever the outcome. Second study had 2.1, also not significant because it's, lower confidence interval touches null value 1. Remember, odd ratio, the null value is 1, not 0. And then Smith study is also 1.8, 80% increase, but still not significant, 0.9 to 3.2. So none of them are significant. But next study is significant and bigger study, and the Chu study is also significant. So when you put them all together, 3 non-significant, 2 significant, overall effect, this is what meta-analysis does. It tells you that 2.2. So it's twice as likely. The odd ratio will be about 2.2. So it's twice as likely to whatever the outcome that you're interested in with the intervention compared to the control in this particular study. So I'm not giving you a scenario. I'm just saying this is one of those most popular way of presenting your meta-analytical finding. It is called forest plot. Why is it called forest plot? Well, I mean, some people say David Forrest, who was working in Oxford, sort of initiated this. So it is after his name, but then other people say this looks like a forest, particularly when you have a lot of studies, look like a forest, so they go for it. Doesn't matter what trees. Yeah, is there a question or something I can hear? Yeah, okay. This is another forest plot. Just giving you study 1, 2, 3, 4, 5, and you've got how many intervention, how many controls, like a randomized control trial. Here is the risk ratio, like a relative risk. You got relative risk from various studies, and then you pool them. The diamond here is a pool. So when you sort of combine them using meta-analysis, that's what the meta-analysis does, is combine all these studies using meta-analysis and give you one estimate. This is much more stronger than the individual studies. That's the whole idea. I'll come back to forest plot again. So this is another forest plot. As you can see, just to show you one point here, that almost all these studies are not significant, but when they touch the 0, in this case is not odd ratio, the outcome here is a mean difference. So the standardized mean difference is almost all these studies, how many, 1, 2, 3, 4, 5, 6, 7, 8 studies, looking at the same thing, all of them are non-significant. All of them have null value 0 in their confidence interval. But when you put them together, you get a significant reduction using psychosocial intervention compared to a control group for particular outcome in this case. So that can happen when individual studies are not significant. When you pool them, you may, if they are having an effect, the effect comes out because studies are generally small. So when you put them all together, this particular combined meta-analytical output, the diamond here, is able to, it has a lot of power because there's a lot of all these sample sizes are inbuilt into this estimate. So meta-analytical estimate, the diamond here, is statistically significant because it has much more power than individual smaller studies. So when you have a lot of smaller studies, put them together and you might find some more solid answer. That's one of those things that we like meta-analysis about. Okay. So moving around. Can you hear me now?
Yes, Professor, you can continue.
Yeah. So because this bar is making a little bit of pain. Okay. So let's go back to the fundamentals because I understand there are medical students also here. So if you have many studies asking the same research question, that's when the issue comes along. So the different researchers often ask the same question. Different countries, they may ask the same question. Is antibiotic good for ear infection in children or not? Or should the women who are going through, these are some of these I worked on, abortion, do they have to be given a prophylactic antibiotic or not? Or does a lot of the things I'm working on these days on a pressure injury, pressure ulcer in hospitalization, does the certain kind of intervention works or not, you know? And so we got a lot of these questions and a lot of people from different countries have looked at it. Even things like prevalence, you know, what is the prevalence of smoking among university students in Turkey? See, one of my undergraduate students was working on that. He was looking at all the papers that are published across Turkey on a smoking level among university students, and then trying to pull them together to get an overall picture, because some parts are the less and the other parts is more. So the different researchers often ask the same question, but end up with different answers. So we can just rely on one of the paper that we pick up and the one we like, and then rely on that for our health policy, or we bring all these papers together and get some kind of average and rely on the average. That makes a lot more sense. Everybody would agree. And if you try to rely on one paper, say one of the papers says antibiotic prophylactic is good, other paper says antibiotic prophylactic is not good, which one are you going to choose? They're contradictory. That's where we sort of say, why don't we take all the evidence, everything published on this, on antibiotic prophylactic for, say, abortion, like we did for the British Journal of Obstetrics and Gynecology, and take the average of all the data that they came out with, and then see what happens. And that is usually considered stronger, and that's what the meta-analysis basic idea is. And most people know average is good, and average gives you a value closer to the truth. We're trying to find out what is the truth out there. So our paper, each one will get a different answer because there are biases in their studies, how they measured, and all kinds of things. So this is what we are after. This is what meta-analysis for evidence synthesis is after. So what meta-analysis does is a systematic approach to analyzing the results from many studies assessing the same research question. So the goal is to synthesize as much information as you can on a single topic to find the best answer, and that become a robust and the best evidence that you can use reliably to make your health decision. Of course, things will change and new papers will come. Then you update your meta-analysis and you change your decision if needed to be. Now, while this meta-analysis being introduced as a very good tool for health policy making, or even a health decision, broadly clinical research decision making, it needs to have a validity and reproducibility. Like I said, if a pharmaceutical is finding it a particular new medication that they are interested in marketing, and all the papers are showing they're all effective, and one of the bigger studies showing it's not effective, then of course if you throw that paper out and then you do the meta-analysis, obviously it is going to show it is very good. But if you put that in, it may neutralize the effect. So of course, we need to have a very good standardized way of doing it. So your meta-analytical results is valid and it can be reproduced by somebody else like any other experiment that we're talking about. So they have set up very good standards that one should follow, not like a narrative reviews olden days. It's a very systematic way of doing it so that somebody can repeat it and get the same answer. And then it's reliable and it's valid. The Cochrane collaboration and JBI, Campbell collaboration and Johannesburg's Institute, all these international bodies are realizing how important it is to have the best evidence properly accumulated and synthesized. They have standards set up, an Institute of Medicine as well. Cochrane is leading on this, and then people are now using. Anybody who is interested in doing meta-analysis for their own, problem-solving issues, please, I would consider them looking at Cochrane guidelines. They'll tell you what to do for searching and defining your question and how do you analyze it. The very comprehensive guidelines exist, and they're fantastic for you to rely on and highly respected. All right, where do we start? We start with the very comprehensive literature review of the topic that you're interested in. So comprehensive search is fundamental for a systematic review, opposed to the olden days of narrative review. Is not important, not that important. They could just pick up whatever comes of their way, and there's no no push for a very comprehensive systematic search of literature that you don't miss anything. So for example, these are sort of graph that I just pulled out. As you can see that frequency of views, these are in systematic reviews. For example, Medline is used about 60% of the systematic reviews. Embase is used about 60%. PubMed. So Cochrane collaboration says minimum 3 major databases. You can't consider PubMed and Medline as two different ones. They are similar. So if you're using Medline, Embase, and Cochrane Library, 3 databases are not bad. But I would even go, most of our systematic reviews that I have been doing, I would go beyond, Scopus, Sinar. And if you have a psychological kind of thing, then you go into the more psychological, psycho-info, for example. And as many as you can, Google Scholar, if you do 10 database search, for example, it will cover quite well and you're not missing any paper. So that's a key in developing it. One of the good things, if you develop the search strategy, the terms and words in Medline or PubMed, and it could be easily modified to Embase, only slightly differences, and then Cochrane libraries and so on. So searching is a skill. Unfortunately, in Turkey that I find, maybe I'm wrong now, I'm away for a while, I hope it's changing, but in Australia, in US, and in Europe, the librarians have now learned to help the researchers how to search, comprehensive search, developing search strategies, searching the databases and getting the PDF and getting the screening things out. They have built additional capacity. I don't know in Aydin and Australia, in Turkey. I'll leave it to you guys. But if not, I think one of those areas that you can push for is for the librarians to build capacity to help the researchers in locating all the, building a search strategy. And the Griffith time, they have a very strong in the library whole section where they help people who are doing systematic review and meta-analysis. They go through the whole process, develop the search strategy, train you, and help you all along. Because it's very, very important. If you miss a paper, then it will be not going to be a good systematic review. So that's something that you can think about and ask your librarian whether you could help. I remember when I was in Kuwait, long time before, the library, there's only one medical school in Kuwait, did not have this kind of training because they are classical librarians. So what we did is we brought some key librarian from University of London and trained our librarian. Then they became very efficient. They brought in all these databases and they did a wonderful job. So sometimes you just have to provide them training and then they will pick up and do a great job. So, okay. So these are some of those databases, as you can see, PubMed, Sinahal, Cochrane Library is free, PubMed, Medline are free, Dynamed you can look at, Google Scholars. Embase is very, very important. Embase, Sinahal, PubMed, these are very important. Cochrane Library, these 4 are very, very important. Depends on your area. If you, as I said, nursing, then you might have to do more. Sinahal is definitely should be part of it in addition to PubMed. Most people start with the PubMed Medline, and then you don't miss any of those. Again, build resources. If people are interested in Aydin or anywhere in Turkey, interested in building systematic review and meta-analysis, they need to work on searching literature and getting help and getting the system to work, because you may not have access to some of those databases, then you are in a bit of a trouble. And then you have access, but then you don't have access to the full PDF for the full papers, then that's a problem too. I hope people are working on that area. So how do you do a comprehensive search? In addition to the electronic sources that I was talking about, all the databases, electronic libraries and the internet and so on, Google Scholars and Scopus and so on, Web of Science. There's also print sources, sometimes journals, textbooks, like not all the Turkish journals, for example, are in the PubMed. A lot of them are not. I hope they will soon get into it. So there may be things that you're looking at, like in China, in Turkey, there are journals they published in Turkish language. They are not got into this database. Somebody searching for the databases may not find them. So we need to also look at the print sources and locate them. That's where the librarians are good at, digging through. And also there are grey literatures, like for example, they are not published in a journal, but they're in a conference proceeding. They may have some data. So the conference proceedings are very important to get. And data from there could be used as well, so we don't miss out. This is called a grey literature. Again, how do you search? Very comprehensive guidelines exist on Cochrane. One of the issues that you might see when you develop a search strategy, comprehensive search strategy, you might use and or not. These are called Boolean operators. So you may say this, tobacco and mortality, for example, both has to be there. Then only you would want it. Your population had to be there. Or if it is a university students, or if it is a adults, or if it's a children, so the P should be there and the mortality should be there. So this could be used. Or you could say either this or that could be there in you're developing, and then not. So you want something to be there but not this. You want tobacco to be there but not children, or something of that nature, whatever it is. So I'm just reminding you that there are ways and means of building your search. Of course, one thing is not going to help you is you just go to PubMed and you just type like when we started, that's what we did when we were young. Just go to PubMed and type blah blah blah. It doesn't work. At least if you're using PubMed, you use advanced search and you build your search bit by bit. What's your population? What's your outcome, and so on. And then you see that you're making advanced. So search had to be done very carefully. That's where I'm calling for librarians of the libraries where you guys are working to help you build their capacity. So these are kind of a Prisma guideline. Is one of those guidelines there. How do you present your search? And so you have to identify the records and say where you identified PubMed, how many, Web of Science, Scopus, and all those electronic database. How many did you identify records related to your PICO? And then you remove the duplicates. You throw them into, for example, EndNote. EndNote have a systematic way of removing the duplicates, and then you end up, because you might find the Scopus and PubMed and Web of Science may be referring to the same paper sometimes. Sometimes they're different, some are same. So we need to remove all those same, and then duplicates, you remove them. That's called screening. And then you look at generally abstract. You don't read the whole paper. Reading through the abstract, you get a very good idea how many records could be kept. Out of that 3,657, 3,569 got excluded. In this case, an example I just picked up. So it's quite a lot of work. 3,000 abstract you can read. How do you do that? You do that. There are softwares for that, like Covidence is one of those software. I'm not sort of selling it to agent or anything, but I think I got it free here, so that's why I use it. And then also Ryan, which is also free, coming from Qatar. Those platform you can put all those abstract system, automatically whatever you search after the EndNote, you can throw them from the EndNote into Covidence or Ryan. Then 3 people blindly read through the abstract. Yes, this is the outcome I want. This is the population is correct. This is what we want. In, out, in, out, in, out. Most of them will be out. So after screening out things that are not acceptable, not related to your PICO, your population outcome, then you end up with maybe 88 papers. In this case, that's the eligibility. So you do the identification screening, then eligibility, and then you got all these papers, how many of them are case reports, systematic reviews, and so on. And from there, how many of them could be used? Some of these eligible ones are systematic review, so you can't use them because they're already using other papers. So some are case report may not be able to use. The full text could not be found, or there were no full text. So you don't have the full data, may not be able to extract information you want. So it end up with 24 studies that you can do a quantitative synthesis, which is meta-analysis. However, you can use all these 88 for qualitative synthesis, but you only have 24 maybe. In this case, that is included for your meta-analysis or evidence synthesis or quantitative synthesis. So this is the kind of steps that PRISMA recommend you do it. And generally, when you want to publish a systematic review, you need to have this PRISMA guidelines. It's very established nowadays. Now, once you come to the eligible papers, and how do you extract information that you can use it for your meta-analysis is there another important key area, because if you take the wrong numbers from the papers, everything is going to be wrong. So if we got a 22 as an odd ratio rather than 2.2, and obviously it's going to mock up the whole thing. So what we do is what they recommended by Cochrane, and what is the best practice is multiple people, 2 or 3 people do it blindly, not knowing each other. They extract from these papers. Even here, even the screening is done blindly by multiple people. Every step is done blindly generally for multiple people, and you compare. Then once you have your Excel sheet ready and you just compare, the numbers are the same. When the numbers are not the same, then you know there's somebody done a mistake. So you go back to the paper and you sort of fix it and agree this is the number, and you have clean data extracted from this paper. Because one of the things when you publish, the authors who publish the paper will know that you have extracted wrong number from them. They're going to write a letter, or they're going to create trouble. So it's not only that, it's not the right way to do. We need to get the right garbage in, garbage out. So the blinded reviews and blinded extractions are very useful. Usually what we do is we get 2 people to blindly do it. In Covidence and in Ryan, they allow you to do blindly. So nobody know what you are screening, which is in, which is out. Nobody know which data are taken. For example, if your 2 people are independently reviewing, say 100 papers, 80 papers they all said yes, but the 20 papers some said yes, some said no. Then you can go back to those 20 papers, but the 3rd person may come in and say, okay, why did you say yes? Why did you say no? Yeah, it should be yes, it should be no, and so on. And then you decide maybe 3 people get involved and decide, or 3rd person educate the discrepancies. That way you're making sure your screening is done properly, your data is extracted properly, and so on. Once the data is extracted, it's in an Excel or whatever the format, and then you analyze them. That is a forest plot or whatever. So the main way of meta-analysis is forest plot. There's also things like meta-regression and subgroup analysis, sensitivity analysis. I'll throw it very quickly. Arthur, how much time do I have? Because I'm putting a full screen.
No, Professor, you have time. You have 40 minutes left, 35.
Give me some warning when I'm...
No, you have time, Professor.
All right.
Don't worry.
Everything going okay? Any questions so far?
Everything, yes. There is a question, but we will take the question at the end of your presentation. So you don't need to hurry. You have time, Professor.
All right. Okay. So now you have a very clear question. What is the population? What's the intervention you are interested in? What's the outcome? Say, for example, population is a woman who is undergoing surgical abortion. And the intervention is, should we give a prophylactic antibiotic or not? The control is don't give an antibiotic, just no need. Outcome is infection. So these are very clear. Then you look for all the papers, exactly what we did. One of my students did, is in McMaster now. He found all the papers published. He found all the trials, because it's an intervention, so we're interested in clinical trials here. He pulled out all the clinical trials. Then he came back to me and said, there was already a meta-analysis done long time before. That's fine. It's 10 years ago. Since then, there are so many trials published, so we can still do that. But we used that previous systematic review to figure out all the papers done before that. But we also did an independent search. So that's a kind of validation method. So we collected all the papers, and then we did the blinded search, blinded data extraction, and then we did the analysis. So I don't have that analysis, but people can look at it on PubMed, BJOG paper. Yeah. So people have this. So this is the intervention, this is the comparison, this is the outcome. In this case is mean difference. So outcome could be mean difference, odd ratio, relative risk, prevalence, incident, doesn't matter what it is, as long as there is a number from each of the study, the same thing that you're measuring. Sometimes you need to transform, if it's a centimeter, millimeter, and all that, we need to change to, sometimes inches to centimeter, you need to transform them. So, but somehow if you can bring them all in the same scale together, then you can put them together in a meta-analysis. How do you do the meta-analysis? Plenty of softwares, Revman by Cochrane, and a comprehensive meta-analysis, and there are free softwares. R can do it, Starter can do it, SAS can do it, even SPSS is doing it now. I wouldn't recommend SPSS. Starter is probably the best, but if you don't have Starter, the free software may be R. R is free and you can do it on R, is pretty good. You can also get free Revman if you are a Cochrane member. I'm assuming it allows everybody to get it. I don't know, because I have been a Cochrane member, so I have access to it. It's pretty good, Revman. I mean, this is produced in Revman, I'm expecting. There's a Cochrane. There are plenty of free way of doing it. And one of the good thing about systematic review and meta-analysis, country like Turkey, there is no much funding, very difficult to get research funding for trials. And ethics issues, there's no ethics issues, there's no funding issues generally. You just have to spend a lot of time searching and getting out. If you have a good library, it helps. And then you can do systematic review and meta-analysis and get published in leading journals. Lancet publishes it, and any top journals will publish it. Yes. The paper that I showed you by Mann is in Science. So what do you want? Nature publishes very high quality systematic reviews. Yeah. Okay. So these are kind of studies, and these are the numbers coming from each of the. This is the comparison arms, the intervention and the comparison, and this is your outcome. In this case, not relative risk odd ratio. It's a standardized mean difference. So these are the sort of confidence interval. These are the numbers, minus 0.68, and the confidence interval. They're all touching the 0, which has been no effect. When you put them together, and it is significant reduction there with the psychosocial rather than the comparisons. Very similar to Eugene Glass's first study, where he showed that meta-analysis shows psychotherapy works. That was contrary to what was known by the narrative reviewers. They all said it doesn't work. There are a number of things here. We can look at it later on. But the diamond is where the meta-analytical synthesize evidence in this case. Now, what is subgroup analysis? This is a forest plot. Subgroup analysis, sometime after you did the general one, you might want to know, is that the same in the males and females, for example, you may say, or is it the surgical surgery for abortion? What we did some subgroup analysis, I can't remember what. Yeah, we did by region. Is that works in the region where there's a lot of infection in Africa or Asia compared to different parts of the world, and we looked at it, and then so we had kind of a. And then I don't know whether we look at by the age group, like old and young. I can't remember what we did, but that kind of thing. So you may say that for young people don't need antibiotic, older people do. Then you can say that the mean age in that study is young, mean age in the study is older. Then you can separate them. Or I'm going to show you later on diabetic, non-diabetic populations could be also. You can just basically separate those studies that are studied in diabetic population or non-diabetic population, for example. And then you do it to see whether your findings are robust. Is this consistent? Maybe the diabetic population you need antibiotic, non-diabetic you may not, that kind of thing. So this is what we call subgroup analysis. This should be decided beforehand. You don't just play around on a fishing expedition. You decide everything right before you start your search. This is meta-regression, another method that I use. Meta-regression is very useful if you wanted to see, say for example, we are working on an infection, pressure injury. So there's a lot of efforts done in many parts of the world to reduce the hospital infection among patients, the bed sores, or pressure injury, pressure ulcers. So we want to see over the period of time. So there are studies done in 1970s, 80s, 90s, and 2000. So if you put this is not that, but I'm just saying, if you put the year of data collection and if you put the infection, if it's coming down, the meta-regression will show it is working. In this case, they're trying to see the CVD risk reduction in one of those studies. I just picked it up. And they looked at reduction in systolic blood pressure. You see, systolic blood pressure is a very important indicator, as you know, for the CVD, cardiovascular diseases. It probably came up as number one risk factor for mortality. I don't know, this year or last year, you can look at it. WHO findings. So if the reduction in SPP is like 20 points, 15 points, 10 points, 5 points, and did it increase your CVD reduction? Of course, the reduction increased, that means better. Each of those circles is a study. There's no, you don't have a raw data. You're not asking people. Usually regression you do based on your raw data, you know, each patient. But here each of those points is a study. So one paper is 1 point. But why is it some are bigger bubble? This is called a bubble plot. Why is it small? It's based on their sample size. So the bigger the circle is a bigger sample size. Smaller circle is a smaller study. These are individual study. Then you do a regression line on the studies. So if you have 100 studies you included, there will be 100 points here. If you only have 5 studies or 10 studies, then the regression is not going to be that great, but still you can try and do it. But you need to have at least 10, 15 studies to do that. So remember, this is meta-regression is different to your classical regression, where individual subject will have a point. Here, each individual study will have a point. So when done correctly, meta-analysis can really synthesize an entire field of research into a much more digestible and applicable format. So for example, here you have this diamond that tells you this is the 1.57 odd ratio, and in female 1.21 odd ratio. So this is your conclusion about this particular intervention that you can take it forward and implement it in when you're making your health decision related to COVID or related to tobacco or screening, whatever you want. There's a lot of work that goes into it. Sometimes there are thousands of papers to screen, but there are a lot of softwares are now coming in to help you and do it systematically. And there are many pitfalls around, but reward is certainly worth it. There is a group of people, not in Griffith. I also get involved with this group recently. In Bonn University, they're developing what they call 2 weeks quick systematic review. So they develop a lot of automated tools that they can do very quickly systematic review. I got involved with one of those groups. It was very tough because almost every day you had to work on it, and then, but we didn't get it in 2 weeks. We get it in 3 weeks. We finished it 3-4 weeks. We finished the draft and kind of submitted it and got published with some comments and so on. It's not 2 weeks, but at least you can do it quickly. But if you use their automated tool for search, even the method writing, their automated way of doing it. If anybody interested, you can go to Bonn University Evidence-Based Center, and then Justin Clark is the one who developed it there. So what are the biases? There are many biases. One of them, very popular one, is a publication bias. So what happens is, as you can see the sizes of these boxes, and at the end it's become almost half of the top. So publication bias is that you plan a study, you undertake the study. Not all those planned are undertaken, most of them maybe. So when you undertaken it, you analyzed it, not all of them get analyzed. There's no biostatistician there. They didn't have time. They got busy. They got their PhD and then thrown it. So they all go into what they call a drawer. It's called a file drawer bias. And then not all of them analyzed are written up. You wrote it and written up. Or even not all of them written up get presented or published. Not all of them get submitted, or even if all of them submitted, not get published. Everybody know in Turkey, people are saying, in the Middle East, I was working, they said the same thing. Oh, our papers don't get published in this journal, they're biased, they're this, they're that. I don't necessarily believe. I think the way of writing has to improve in some way, in my view. But so if you plan this much, 100 studies, only about 30, 40 studies get really published. And then out of that, how many of them get used? Again, where did you publish it? If it's published in an electronic database index. If you publish in a place where it's not indexed at all, nobody's going to find it, right? So it has to be an index journal to get it used. So this is what happens. So this is called a publication bias. So there are studies that are already done and they show there is significant effect or no significant effect, but they are not there for a meta-analyst to use it. So that is a major bias. So what is the bias here is that some of the studies already done are not included in your meta-analysis, and we call it a publication bias. So it arises because of file drawer problem. You are not able, not every study that are planned and undertaken have gone into to index publication. So when you search the databases, it picks up. That's why we're saying that look at the grey literature, look at the different languages. If you're interested in something on Turkey, you should look at all the Turkish language journals, whether they're indexed or not. You need to look at the list of them. You need to also look at conferences, like conference presentations, and you get those abstracts from there, and then write to the author of that conference. Have you published it, or can you share your data with us so that we're doing it? So sometimes it's quite a bit of involvement. Yeah, there are various bias under publication bias. If it's not significant, it doesn't get published sometime. Yeah, sometimes citation bias and so on and so on. These are some of the things. I don't want to go too much into it. Time lag bias, you already done it, but it took 2 years for the results to come out, and then too late. Language bias, sometimes it's published in Japanese, Chinese, Turkish or something. Portuguese in Brazil, it doesn't get to English. Most of the systematic review I did, almost all of them, maybe apart from few, is restricted to English language, and then that is obviously pulling things out. Particularly if you're working on alternative medicine or complementary medicine, obviously you need to have a Chinese papers to be included. Awful lot of paper, huge number of papers coming from that part of the world get published in their own journals. And also even Turkey has a lot of alternative medicine ideas and various complementary medicines. They are all published maybe in Turkish journal, or never published. They done the studies. So all these biases had to be taken into consideration. But what can you do about it? You do your best. You try to find. That's what we call grey literature, and look for conferences. Write to different group and teams and see whether have you done it. Most people don't do that, but it's good to do that if you can very quickly. And then what you do is, but what they say is that the things that are, rather than relying on 1 or 2, 3 papers, you've done your best to accumulate almost everything that are out there in a visible world. And that evidence may be stronger than 1 or 2 papers that you're relying on. There are statistical methods that you can use to see whether there's a publication bias. Funnel plot, LFK, and Doi plot. Funnel plot is like, if you can see that, this is the effect size, and this is the standard error. I mean, I don't want you to worry too much about it. So this is the idea, is that the significant results are going to get published whether they're small or big. Non-significant findings. Suppose you did a study, it's not significantly different, this new medication or this new plant-based is not helpful, it's not going to get published. New plant-based is helpful in particular outcome, it's going to get published. So you see there is a whole gap here. So that indicates that there may have been studies done, but because it's not significant, they didn't get studied, called a missing study. So this indicates, for this funnel plot indicate there is some kind of bias. If the funnel plot is complete, both sides, then you can think that maybe significant and non-significant small studies got published. And the LFK and Lewis and Doi, who are my partners in Queensland, they develop indices and working on it. We got a huge grant recently to work on this publication bias, but it's a very difficult area. If somebody is very concerned, best way is to contact the groups, go through it, dig through it, and have a very strong librarian to support us. Yeah. So again, these are some of those steps. Very quickly, formulating the research question. Like a PICO structure for evidence-based medicine, people who are familiar with it, participants or population. What is your intervention? What's the comparison you are interested in? What is the outcome? And so on. If it is a set of intervention that you are interested in, then you'll be looking at mostly clinical trials. Sometimes you may be interested in exposure. maybe simply prevalence of smoking, incidence of COVID, incidence of anxiety, incidence of mental health issues among university students, or whatever it is, then your PICO will change to population, exposure, and outcome. You don't have an intervention. You don't have to have intervention. So then you can look at the cohort studies, and you can look at cross-sectional studies to include them. Then you have to have a protocol. You have to have very clear protocol, and even registering the protocol is recommended. There are places like Prospero. Prospero registers your systematic review, and it's a good practice to do that, because you said this is what we're going to do, this is how we're going to search, this is our PICO, then you don't deviate. Otherwise, while you're looking into the literature, you might move into something else, and that's going to be not very good way of doing it. Here you publish it before you're doing it, then you start searching and you stick to your protocol. That way it's better. Of course, while you're doing one meta-analysis, you may get other ideas, then you do a new one and register. And you develop what's your inclusion exclusion criteria very clearly. What kind of age group you're going to include? Are you going to include this or that? Are you going to include people who have cancer and CVD or diabetics or not? Or are you going to include children or adults or male, female, generally included, unless the gynecological things? And what are the exclusion criteria? What is it that you're going to exclude? And so if the outcome is not measured in any way, then you will exclude, things like that. And then you do you develop a search strategy, and then you do a comprehensive search. That's where I'm highlighting the help from the librarian is very important. Then you look at the quality assessment. It's another area that I don't want to spend too much time on. There are systematic way. Cochrane has his own tools, systematic way of assessing each of those paper. Is it in a good quality or not so good quality? High risk of bias or low risk of bias, selection bias, all kind of different types of bias. Their sample size is big, goes representative or not. And then we put that one also. So in our systematic review, we say that out of the studies we synthesize, half of them are low quality, half of them are moderate quality. So take our evidence with a pinch of salt, because there were no good quality studies. And then you do a data extraction, like I mentioned before, blinded way, and you analyze them using forest plot, meta-regression, subgroup analysis, sensitivity analysis. Like you can analyze only the good quality studies. You define your studies as a high quality, low quality, and you can analyze them in a sensitivity analysis only the good quality studies to see are they saying the same thing as when you put all your studies together. Then you come back to the assessment of the level, that is called a grade, and new things that have been developed in McMaster by Gordon Guyatt, who actually developed the term evidence-based medicine. He's the one who coined the term evidence-based medicine. He now developed something called a grade, GRADE, grade, like grade 1, grade 2, where he shows how you can grade the evidence comes out from your meta-analysis and systematic review. It's a good thing to look at, and he has done a lot of work. Gordon Guyatt, with whom I have been fortunate to teach EBM around the world. And then you do the research presentation and you publish it in a journal. Please do publish it in a journal, otherwise it becomes a publication bias again. And then, generally most of the journals are accepting very good quality systematic reviews if it follows all the protocols and done correctly. Some of those would not accept if you didn't register your protocol. So you need to be wary of all that steps. Best place to go is Cochrane guidelines. If you go into the Cochrane guidelines, there's handbooks. Libraries should have those thick handbooks. You can look at it and learn an enormous amount of wealth of information. So these are some of those steps. Again, and study selection, data extraction, quality assessment or risk of bias. This is to just at the end to see. This is not read it for meta-analysis. This is to see how many studies you included are good quality, how many of them have a lot of bias. Then you do the meta-analysis and qualitative synthesis as well. And then you interpret your finding and assess how good is the evidence. That evidence could be then used in your decision making. In hospitals, they use meta-analysis nowadays. Should we do this or not? Should we, so our paper that we did about prophylactic antibiotic, I got a lot of email from many hospitals. Even Queensland, they use that for their journal club to make a decision: should we give prophylactic antibiotic or not? So they do have weight in doing that. Okay, so going back again to forest plot, I hope everybody, this is very important to understand how you present your meta-analysis. So these are different studies as a study ID, and these are the confidence interval, and the dot is what is a point estimate. The longer the confidence interval, smaller studies. In this case, they didn't make the sizes different. And the large, this diamond at the bottom, I don't know whether you can see, that is the meta-analytical finding. So as you can see, that is significant, not touching the zero line or a null line. So you have almost all the studies are not significant, and I showed you this before, I think. And when your meta-analytical finding is significantly favoring one side or the other, that is very promising. That means because each of these individual studies are not powerful enough to detect the effect because they're small. When you put them all together, the effect came out. This is great, and then you make a decision based on, you can say this is effective and started to put into practice and see how it works in real life. And then if it doesn't, then you know, the cycle continues. And of course, there are new studies comes, then you update it every 5 years, 10 years. So we do a lot of updating. So Cochrane, I've been a Cochrane member for 15 years or so. So what we published already in them, they're very high impact library. From library, you can publish their review, very rigorous. Then they will send you automatically, now your review should be updated, and they actually do the search and say there are so many papers came out on this, so please update. So we just run an update, rewrite, another paper comes up. Yeah. And then good thing about Cochrane is not only they published in the Cochrane library, now they're allowing you to publish the Cochrane paper in an abridged way. I mean, Cochrane is very thick. Oh my God, their papers are hundreds of pages because they need so much detail. They allow you to make it very small into 3-4 pages and published in a classical journal. It is accepted, and they have deal with that. So you get, you know, very good visibility of your work. So in this study, I mean, another study, for example, 1, 2, 3, 4, 5. This is not true, I think. Just created in India, Morocco, India, Bangladesh. I don't know where I picked this up. And it's about what, I don't know, all of them are not significant, and even your overall finding is not significant. So putting them together did not change your overall conclusion, and most of the studies, but some of the studies showed left and some are right. That means it's favoring or it's opposing. And when you put them together, you got much better picture. That means there is no effect. So you're much more confident. Okay, this is about empowerment and more empowerment of some sort. This is about women studies, I think. So meta-analysis is the statistical synthesis of evidence from many studies that are looking at the same concept, same idea, developed by social scientists 1970, to be precise 1977 by Eugene Glass while he was doing a PhD, and he had a psychological breakdown. So he wanted to know psychotherapy work, and when you look at the literature, all of them said it doesn't work. So he just took all the papers that he could get hands of, and then he put them together. You see, he's a statistician, he's a very strong statistician. He put them together and draw this forest plot and say it's working. And then that's what he called meta-analysis. So since then we are calling it meta-analysis. Yeah, and more, I mean, Cochrane here, this is the symbol for them, Campbell collaboration, 3IE and IDGG and Institute of Medicine, JBI in Australia we have, Johannesburg. All of these people are promoting and giving a lot of resources. Go to their websites, you find a lot of information free. Oxford University Evidence-Based Medicine Center also gives you. So a lot of these resources are freely available because they want to promote this. And Turkey, in my view, could do a bit more on evidence-based practice. You know, their protocols could be updated and so on. But I know they're using Dynamet and all those updated protocol already there. But we could do better. So what we generally, I don't want to go into too much of this, evidence review and synthesis, something that we talk about that will help you to make evidence-based decision making. And then so your decisions are going, hopefully right decisions that's going to be effective and helpful, not wrong decisions. And you know how many health policy decisions that are done wrong. And we know during the COVID, how many of them done right, how many of them done wrong. It's funny that I was in Turkey, my wife got COVID and she was in ICU, and where I have been publishing papers on COVID, I was in the COVID advisory board, and about chloroquine is not effective. I did a meta-analysis when Trump said, chloroquine is working, so we just did the malaria medicine. We quickly did a very big meta-analysis and putting all the meta-analysis and all the studies together. It's not working. While I know it is not working, I know my wife has been given the medicine right inside intensive care in one of those, I don't want to give the name of the hospital, somewhere in Turkey. And then I was trying to talk to the people there, and you have no access, so messy and so crowded, and you know the time that COVID. So a lot of things. And then I also did a work on steroids with another group, whether it's working on everything that I have shown. I found in my meta-analysis is not working. I given to my wife. I just joke that all the time. I say I have no control. I tried to call, nobody would listen. I mean, people in Turkey would know what I'm talking about. Yeah. Anyway, so not a criticism, but this is not only in Turkey, all around the world, we have the same issues. So it's not all evidence-based decision-making in healthcare. That's what I'm trying to point out. So key important thing about meta-analysis, you need to have some kind of quantitative numbers. If you don't have these numbers or ratio, relative risk, or a mean difference, or a prevalence, or an incidence, some numbers from their studies, if you don't have numbers or words, or qualitative studies, you can do it, but it's not meta-analysis. You can do a qualitative systematic review, no problem. So it has to be done in a more qualitative way. Sometimes you can turn some of those terms into numbers in a scale and so on, but generally you need to have some numbers. And it should be all systematic. All the papers have to be systematic research, like we mentioned. And you combine them together. That's what the meta-analysis is done. And basically you're saying that what has been done until today, previous research, and then you generate a new knowledge. That's a conclusion that could be very valuable. So this is quite attractive. No funding, no ethical review, no HRAC, or no ethics requirement, because these are, you're not doing anything, you're not seeing any patient. Your patients are papers. Okay, so what can be meta-analysis? It has to be empirical or numbers, and so it produces quantitative results. And it should be same construct and relation. This is a major issue because there may be 20 papers, but they all are slightly different. Some of them said adult patients, some of them said patients between 40 to 50, some of them said we only took 20 to 25. Are we going to put all of them together or different? Most of the time, you probably put all of them together, and then you can do some kind of subgroup analysis, young ones, average age is young, or you can do a meta-regression, is average age is young or old, make a difference, and so on. So you don't want to throw things out. Provided the outcome that you're looking at is measured and the population is more or less the same, the human being, it should be fine. Yeah, so effect size makes the meta-analysis possible. So I was talking about odd ratios, relative risk. These are the numbers that we are interested in. Any one of them, risk different, mean difference, median difference, rate ratios, hazard ratios, any of these that are in these papers you can publish. Sometimes, for example, you may not have the odd ratio, but you have the number that you can calculate the odd ratio very quickly. Internet has plenty of online software. You have a 2x2 table, throw the number in, it will give you the odd ratios. So it's fine. Sometimes numbers there, they don't have the measures. They didn't have gone into statistical modeling correctly, but they have the numbers. So you throw them in and you calculate. Most of the time, these days, they would have these numbers that any of those you can, or prevalence, or incidence, or correlation. We can put together correlation report in 10, 15, 20 papers together into a forest plot. No issues. So you need to have that number. That's called effect size. I can show you an artificial meta-analysis just to get your idea. Yes, Artha, I can go on with this.
Yes, Professor, you can go.
Yeah, is it going okay? Not too
Yes,
fast?
yes, everything is clear and okay, Professor. Thank you.
Yeah, I tend to go a bit faster. Everybody
No,
says
you don't need to do. No, you are welcome,
yeah.
Professor.
All right. Okay. So let's talk about decaffeinated versus caffeinated. This is not true. It's just artificial. Which one causes headache? Decaffeinated or caffeinated? You probably have an answer. So this is a decaffeinated and a caffeinated. And then which one is causing headache. So we have exposure is a decaffeinated caffeine, outcome is a headache. Okay, so let's see. So these are the different type of coffee studies. So Amora coffee is the author's name, and Delhi, all this created, as you can see, Mama Kappa, Morocana. You don't have, we have mocha here. You don't have mocha in Turkey. Turkey only have Turkish coffee. Yeah, Nose coffee. I'm just joking. So these are the different things that we just synthetic. These are the year of their publisher. These are the author's name. So those who take caffeine, and 2 out of 31 had headache. Those who took decaf, 10 out of 34. So these researchers have given 31 people caffeinated coffee and 34 people decaffeinated, randomized trial. 34 people, I mean, it's not always equal, right? You try to be equal, it doesn't. Randomly you allocate, you're into caffeine or decaffeine. They don't know it, but they just drink and tell us whether they had a headache. So 10 out of 34 decaf had headache. Looks like decaf is bad. And the other study, 10 out of 40 had a caffeinated, had a headache. 10 is the headache, 40 is the sample size. Here is a 9 out of 4. Here is a caffeinated seems to be bad. And Mama Kappa found also caffeinated seems to be a bit poorer than the decaffeinated is better for headache. First study has decaffeinated is bad. Moroccan had very few headache, 3 and 1, 4 people, 3 in the caffeine again. Caffeinated is causing more headache than the decaf. And by the way, these are not true at all, so don't believe in this and stop drinking decaf. Decaf is for me always good. No, Nose Cafe has shown caffeine is really increases your headache than the other 9 only. And I don't even know, Ohalahasa, I don't know. 4 and a 2, 8. So these are the data that you extracted. These are the studies you did all the search. And only these studies are looking at the caffeine and decaffeine and the headache. So you, in your search, you will have a headache or something like a head pain, or all the words that can be expressed as a headache have to be there, not just headache or head pain or whatever the words you can have, you should be there. Here again, you need to have a coffee, not decaf, or coffee drinking, various different words have to be, you have to be very creative what kind of words they can use, you know, and all that had to be there, otherwise you'll be missing it. Not everybody may be calling it a headache. Some may be calling it pain in the head, or whatever, forehead pain. Anyway, so this is the forest plot. So this data is extracted, and then we develop a forest plot. As you can see, these are the study authors and the year of publication. This is the caffeinated, how many events? As you can see, 2 out of 31. So 2 people had a headache, and 31 is a sample size. 10 had headache, 40 is sample size. The same study, you had a 10 had a headache out of 34. So these are the numbers. And once you enter these numbers, and then automatically it will calculate the risk ratio. This is like a relative risk. And as you can see, the first study is showing that the caffeine is very good, favoring the caffeine, obviously, because there are more people with the decaffeinated had a headache. So it's showing that caffeinated is better for the headache. All other studies are showing sort of decaffeinated is better for the headache, favoring the decaffeinated. This is a favoring the caffeine. And of course, this 0 line, null line, show any studies that are crossing it, that means not significantly different anyway. When you put those studies together and in the computer does the meta-analysis, shows 1.38, that means it is favoring decaffeinated, 38%, in a way, 38% less headache in people who have drinking decaffeinated compared to the caffeinated. So decaffeinated is winning here. And still though, it's touching the 1, therefore it's not statistically significant. As you can see, the p-value is about 0.20, not less than 0.05. So it's not statistically significant. There is a tendency towards decaf to do well. This is called a pooled effect size. And the confidence interval of that is narrow, which is the diamond size, because you have so much sample size. Each of these studies have this many sample size, but we have 277 plus 290, what is that, 500 something, 600 sample size to get this one. Each of those studies are smaller. When you put them together, you get a much stronger pooled effect. Then we can rely on that to tell the world is decaffeinated is better or caffeinated better in terms of headache outcome, not anything else. So how efficient you can study or how efficient you can work is a different outcome. Here they're looking at headache within 24 hours. You know, in after 24 hours, did you have a headache or not after drinking? I mean, of course, there are a lot of other factors can cause headache. So these are not controlled, but yeah, this is what they do. These are all supposed to be trial. As I said, this is not true. It's just somebody just sit down and imagine and put all these names just to make people fun. How is it done? The good thing is you don't need to do anything by hand. The computer software, this is a comprehensive meta-analysis. Again, you buy this. So I'm not promoting this. Yeah, so we just add the studies one by one, add this white column, the author's name, and how many are treated, and how many got the outcome, how many is the sample size in the control group, how many got the event, how many the sample size in the treated group, if that is a intervention. Then all these odd ratios and confidence interval yellow part is already calculated. So as you can see, in this case, there are 9 studies. And then these are the events in the treated group. These are the sample size. It's not a capital, it's a real study. It's the control, and then how many, all of them, odd ratios are all calculated. You can change it to, in this, you want odd ratio, you want relative risk, you can do whatever you want. In software is very, very flexible and easy to use. And then it creates the forest plot for you. Here is the forest plot. And these are the studies. These are the odd ratios, the lower and upper limit, p-values, and so on. This yellow at the bottom is your pooled estimate, which is significant and favoring the control, I'm assuming. Yeah. So that's the kind of, so it's very easy to do. So let me show you a real example. This is a JAMA internal, it's a very high impact factor. Also, at the same time this paper got published, there was a Lancet paper also got published. This is a question is, when somebody has a multivessel disease, should they have CABG or a PCI? Should they open heart or should they put a stent for a long-term mortality? This is a real study now. These are these are artificial study I showed, but here is real publication in a JAMA Medicine 2013. It's a good question. You know, people who have MI and should we have stent? Should we have CABG? Yeah, I myself went through this question. Yeah, but anyway, so which one is good for a long-term mortality? In this case, what is a PICO? Long-term mortality is the outcome, not the hospital mortality. Long-term mortality is your outcome. Your intervention is CABG, coronary artery bypass, and your control group is stent, PCI. Your population is multi-vessel people with a multi-vessel disease, not for the one with a single vessel. So there is more than one block on your arteries. So what is best, stenting or a surgery? If you ask anybody, stenting is the best because it's not opening, not going through anything. Within 2-3 days, you can be back in your work. And if you're a workaholic, surgery, you need to, suffer and, could be infection risk and so on and so forth, and invasive. Stenting is much less invasive. So there's a lot of studies done. The objective is a lot of studies done comparing the CABG bypass versus stent in people who get a heart attack, blocks, but they have not looked at the long-term mortality. So in-hospital mortality and the other outcome. So they look at the randomized control trials, that is comparing randomly they assign bypass or PCI, and they found 6 trials, enrolled 6,555 patients. They follow up for about average follow-up is 4.1 years. That is good. So they did a very good systematic research in Medline and many other databases. These are the search terms they use: bypass or bypass, PCI or stent, multi-vessel, 3-vessel, 2-vessel, and so on. And they had a much more broader thing. And they also said limited to randomized controlled trials. They didn't want anything other than trials. So they searched Medline, Embase, several other databases, Cochrane trials, and all of the Scopus. And then they only found, so they had 102 studies they found, and 96 were excluded because they didn't have not multi-vessels, they didn't have not a trial, not randomized, and so on. Some are reviews and case editorial meta-analysis. You cannot include them. They ended up with 6 trials, and a lot of the trials have names, as you know, Arts and Mars and Souls and Podia. And before this systematic studies, many of the people were relying on Freedom or Acadia, had cardiologists always say, we based on the freedom study, we are using this, or we are making this decision and so on. Now, you got all those randomized trials that are comparing CABG to stenting are put together in this study. So they extracted with the independently, 2 of them. I'm going very fast because, yeah. So they extracted the number of events and how long they live in each of those groups and so on. So they had this table they prepared. So these are 6 studies, and how many patients in each studies, and how many had a CABG, how many had a PCI, and what is the follow-up time, and what are the outcomes they measured. Death. All of them have death. That's the main outcome. They also had other outcomes, secondary outcomes. Why not? And they also looked at some other detail, what kind of stent, bare metal or drug-eluted stents, and so on and so forth. So they measured the risk ratio from each of those studies. So this is their forest plot. So arts is showing favors CABG, but not significantly different. Mass is also favoring CABG, is more protective for long term, but not statistically significant because crossing 1. SOS is showing significantly better CABG and is statistically significant, is not crossing. And cardia is showing no effect, whether CABG or PCI is the same for long-term mortality. Syntax is the one showed that CABG is better, significant, and freedom is also showing significant better. The bigger size is a bigger data sample size. As you can see, these are bigger studies. Bigger studies have a bigger block, and the smaller studies have a smaller rectangular sequence. This is the pool meta-analysis. When you throw these numbers into the computer, it gives you what it says is significantly better. So it is favoring the CABG, showing that CABG is 0.73, almost 27% reduction in mortality, long-term mortality compared to the PCI. So there's quite a lot of reduction due to CABG. So yeah, so there was a significant reduction in total mortality with the CABG compared to PCI. When you put them together, but individual studies were not showing, although some of them were showing, but when you put them together, you got a much stronger, very highly significant. P-value is less than 0.01. Confidence intervals are not crossing 1, as you can see, 0.62 to 0.86. So they concluded and they published. It's a very quick, can you imagine, only 6 they had to put it in, but they did, very easily they published. JAMA intermediate, very high impact, very, very high. In patient with MVD, multivessel disease, CABG lead to an unequivocal reduction compared to PCI in terms of long-term mortality. These findings have significant implications for management. Of course, hospitals will change their management after this, and it is being used until today. But then there are a lot of other studies have come up now, and the PCI has improved, the stenting method has improved. So there are more debate now than at that time. There's another study saying that does dietary fiber reduces the blood sugar. This is in Archives of Internal Medicine, also high impact. This study is a very messy study, not as clean as the previous study. And these are their search terms, and they did, this is the 100 studies they found, and then 28 excluded, 72, then only 24 studies they could include in the meta-analysis because, based on the data. So this is called a Prisma diagram. You need to have this flow chart in all the systematic review. So these are the kind of data they extracted independently. So each of those lines is a study, and what kind of data they had, and so on. I'm not going to go into detail. This is a forest plot. In this case, they sort of plotted it from a smallest effect to the highest effect. It's called a cumulative forest plot. And as you can see, most of them are not significant, and overall is very narrow confidence interval. Okay. So in terms of quality assessment, the validity of the systematic review at the end of the day depends on how strong the scientifically the papers that would include. So garbage in, garbage out. So if you have very strong papers, so in this cardiovascular study, strength of this is all these 6 studies were pretty high standard trials. So good trial. That's why this conclusion has been very strong until today. It's somehow holding, not fully. So in this study, there were a lot of variability, as you can somehow using different type of fiber, soluble, insoluble. So it's very difficult to rely on the conclusion fully. So the validity of the systematic review depends on what kind of scientific rigor the individual studies that go into it. Yeah. So we work on an area with Suhail Doe and myself on a quality effect model, and we try to introduce quality as a very important determinant in meta-analysis, and we come up with a new model, but very mathematical, don't worry about it. One of the other problems we have in addition to bias, heterogeneity. So for example, if you look at the plot 1, it's very nice and everybody seems to be showing forest plot A, similar kind of thing. If you look at the forest plot B, it's all over. Some are showing that the treatment is good, some are showing the control is significantly better, it's all over. So it's very heterogeneous. So obviously when the studies are showing, one is saying give antibiotic, one is saying don't give antibiotic, when you put them together, it's really problematic because why are they so different? You started to wonder, so much heterogeneity is, shakes you. But if you have very homogeneous studies like in the forest plot A, your findings become much more reliable. So heterogeneity is a major threat to evidence synthesis in my view. So evidence synthesis is a key to get the robust and the best evidence required for any type of health policies that you make. And meta-analysis offers a very rigorous, transparent, systematic framework that you can repeat it and get the same answer for synthesizing data that can be used for a wide range of policy decisions. So that's where I stop. Back to, oh, sorry, I couldn't see my photo, so I hope you could see me. Yeah, anyway, yeah. Yes, Arthur, over to you.
Yes, I open my voice. Thank you very much. It was a very fulfilled information, a lot of information, especially about the health evidence, health policies, meta-analysis. So everything was here that you talked everything for, especially for the how to design a research, for the, I think that for the new academician and the young academician and cited, it was a very valuable presentation. So thank you for sharing your knowledge and sharing your time with us today. I will take some. I will take some question. I think that in the chat box we had one question while you were doing your presentation, and I would like to read that first of all. The question is here, Professor. Dear Professor, I have a question. What role do systematic review and meta-analysis play in evaluating the effectiveness and safety of interventions in healthcare and public health? And what are the best practices for conducting them? Maybe you can have a look at the chat.
Are you? Yeah, I can't see in my chat box. I can't see that. I don't know why. Let me just see. It's not appearing. Oh yeah, okay. I have a question. What role do systematic meta-analysis play in evaluating effectiveness and safety of intervention in healthcare and public health, and what are the best? Absolutely. Today is an evidence-based world. I can tell you where I'm sitting at the moment in Australia. Almost all the healthcare practices in the hospital. I'm in the, I was visiting cardiology the other day in Children's Hospital. They're all based on meta-analysis and systematic review. Everybody, every doctor now should be able to read a meta-analysis, and their guidelines are based on, the levels of evidence. They say, okay, in the hospital you say, shall we do this? Shall we give this medication? They say, yes. What's the level of evidence? Level evidence 1. Level 1 is coming from a systematic review and meta-analysis. So most of the developed countries, I'm assuming even in Turkey, the decisions about what to treat, how to diagnose, is it an X-ray or an ultrasound or what kind of ultrasound? All those diagnostic decisions, treatment decision, prognosis, risk factor decision, all of them are done based on systematic review and meta-analysis that get published. And how much of them get transferred into various parts of the world, I don't know. But here, when there is a new systematic review or meta-analysis get published, immediately in the journal club, they will throw it out and they will modify their protocols, hospital practices if needed. So there is almost every hospital have a business intelligence teams or evidence teams, they keep looking at new evidence coming through. In conferences you go, they will be presenting the new evidence related to that. You know, if you're hematology, you've got hematology conference, ASH conference will be having all the new evidence, new papers presented, and so on. It's a huge role now. It wasn't the case. When the evidence-based medicine started with the David Zucker, it wasn't that much. It was haphazard. Now it is very much so. In the medical schools are teaching evidence-based medicine from year one, and they will be able to look at the evidence and the grading the evidence. And most of the medical students graduate from Australia are able to read meta-analysis, understand, and most of the protocols or guidelines. If you look at the guidelines that are set up in the hospitals, that are updated every 3 months, 6 months, depends on studies, are taking the systematic meta-analysis as the highest level of evidence. That's where I showed that triangle. I'm sure guidelines, I'm not sure how guidelines in Turkey are done in the hospitals. I'm pretty sure they're following, you know, like if say cardiology, American cardiology guidelines, they are based on systematic reviews. So is that the question they're asking? Yes, safety of intervention. Or not only they're looking at whether this is it safe or not safe, also is it effective or not effective. They're also looking at the adverse event. Is it safe? Okay, it's effective, but it can be not safe. It can reduce, but it can also create a new issues. So they're looking at all that. In most of the meta-analysis, have to look at you know, effectiveness and the safety. Not only that, a lot of meta-analysis are now done to look at the cost side of it. You know, okay, it's effective, it is safe, but is it hugely costly? Then we can't afford it. If the medication costs, you know, $2,000, like some cancer medication for every month, how can a country like, you know, Turkish may not be able to handle that? You know, although Turkey spend a lot of money on healthcare and drugs. But one of the good things is they produce a lot of the things there. But the new medication, until it becomes, you know, license become open, it's going to be difficult to implement some of them. Yeah. Is that what the question meant?
Yes, Professor. Thanks a lot.
Yeah.
And another one is here. Yes, thanks a lot to you. It was clear. My question is, what is the role of patient-centered outcomes research in shaping healthcare policies and promoting patient engagement in decision-making? Another question that is on the chat here.
Yes, so the whole evidence-based medicine framework is built upon best evidence, patient preference, and clinical expertise. So these are the three arms. So not just the robust evidence, you need to also see the patient-centered outcome, patient preference. So the lot of patient-centered, patient's preference studies are extremely important, and you may come up with various kind of intervention, but that's not the patient's preference, you know. So then you might think that having antibiotic 3 times is better than making into 1 tablet in the morning, but the patients may remember or compliance or 1 tablet is better than 3 times or 4 times, then that has to be taken into consideration. Yes, there's a whole heaps of patient-centeredness and evidence-based medicine population movement. We always push on the patient-centered outcome. I have written articles on that, and I've even written so many editors' letters because I got very annoyed. For example, there was a systematic review done in US where they found the few male doctors are going into gynecology. So they somehow said we need to change the medical school to include, encourage, push the male doctors into going into gynecology and obstetric gynecology. Then I wrote an article to the editor. I said, where is the patient preference? A lot of the females in the West and the East, they would prefer a female to be examining them, and the male, there could be that preference for, particularly for childbirth and so on, and examinations of, you know, invasive nature. And then why do you not take that into consideration? And then actually the editor published it immediately. So these are the kind of push we say, just don't ignore the role that what do the people want, you know. It may not be a good example, but I'm just saying a lot of patient-centered research is extremely important, but we should do more. We should do more because pharmaceuticals are more interested, unfortunately, in showing the effectiveness of the drug. And then we need to move on beyond that and to say, I mean, the very good case is that for people who had a cardiovascular events, so you have, I don't want to give the name of the drug, there's one drug which is very, very effective, but it's terrible. Almost 60% are switching from that to old drug. There's an older drug, not as effective as a new one, but is much better for the quality of life. So this drug kills the patient, just put them to sleep and cannot stand up. So obviously it's better for them to have an older drug, which is at least giving reasonable quality of life. And also it is effective, 90% may be comparable. Even so, these are the issues we need to really take it. Otherwise, patients are going to go without any medicine. So it's better to have 90% than 0%. You know what I mean? Yeah.
Yes, I'm checking. Thank you, Professor. Is there any other question from chat box? Here is no. But we have two questions, but due to the time, the last one it will be from students that are watching you from their class, listening to you. They ask that, what are the long-term impacts of evidence-based policies on healthcare outcomes, cost effectiveness and population health, and how can these be evaluated?
Yes, so there is, it's a good question. There's a more and more cost effectiveness meta-analysis are being done now, not just effectiveness, even how costly is this particular decision is, because healthcare is a very expensive business, and I'm sure a lot of such discussion has been going around. And then, so we need to evaluate at a population level, say how sometimes you may have an intervention which is only very cheap, but you can achieve a lot. Sometimes it's very expensive, and you might spend that dollar in something else where you can achieve a lot more for the population. So you need to look at it in a population-based perspective rather than individual. Yeah, like for example, when New York decided not to offer the salt on the table on restaurants, they said, no, don't do that. I don't know whether they changed that policy or not. That has reduced, that's something very simple to do. It doesn't cost much legislation, and then that will bring the blood pressure down in the population and would have a lot of reduce the hospital admission, CVD event, and as you can see, SPP, systolic blood pressure is a major problem, a key indicator for mortality and admission. So things like that, or things that are you're putting cycle tracks. Would in Brisbane they spend a lot of money on putting cycle tracks. So if you see when we drive, we have a separate cycle tracks and dedicated, even covered with the shade. It's expensive business, but that would improve the health, improve the mood and the mental health, and so people come by cycle. Sometimes people cycle for 20, 30, 40 minutes. My grandchildren now going to school by the bicycles, although they can go by others, other means. There are plenty of other transport. So these kind of decisions, how it affects population is what we should look at. Sometimes the cheaper options that are very useful, that have significant big jump. Sometimes there are choices that are coming out, particularly pharmaceutical driven. I'm sorry to say that they're very expensive choices and it doesn't get us a lot. So if there are cheaper alternative complementary medicines, we need to be open to look at them, not to close the doors. Yeah, I mean, Turkey being a very creative country, they could come up with a lot of health promotion initiatives that's not expensive, but that could have a significant impact in the whole population when it is implemented. It's a very good way of thinking. I don't know who asked that, but I'm very happy people are thinking in that line. Yeah.
Besides this question, of course, there are a lot of questions from students, but we already share with you the contact information. So if they are especially interested in the meta-analysis, maybe they can send a message to you or contact with you, Professor.
Yes,
so because it was a long time and we don't want to take a lot of your time because you did a long presentation. It's a good one. And so we are at the end of this session today. For today, we are going to complete now. So thank you again, Professor, for sharing your knowledge, for being with us. And we wish you a good day, and all of our speakers that share their knowledge with us today. And of course, attendance, the students that are in their own class, they already was all the day there watching us. So tomorrow we will be again, and we will start tomorrow. We have the program shared with you at 9:30 according to the time zone in Turkey. And let's see you tomorrow. And thank you again, everybody, for being here.
Thank you.
Anybody would like to add something? Okay, so I'm going to close today's session today, and let's meet tomorrow. Thanks again, and have a nice day.